what is it called? It is producing a lot of platelets or a lot of neutrophils or whatever. So reactionary leukocytosis and thrombocytosis is also ruled out with this. So this is a complete picture that we should all look at.
Yes.
Sneha, just one question. Can you differentiate between thalassemia minor and iron deficiency anemia based on your this report?
Yes, ma'am. In iron deficiency anemia, as it is microcytic hypochromic picture, there is decrease in MCV, MCHC, and MCH. In thalassemia, we will get the report suggestive of MCV, MCH, and MCH. All are normal. RDW is mildly reduced or normal.
No, in thalassemia minor also you may have MCV which is less than 75, although it is not so, but in iron deficiency, all the indices will be low.
All will be.
Yes.
Whereas MCHC
Yes.
might be normal.
It will be normal in thalassemia minor. Yes.
And RDW will be narrow. It will
Narrow,
be
yes.
It will not be like this.
All cells are equal size. There
Yes.
is no poikilocytosis with thalassemia minor. How do you confirm whether it is thalassemia minor, Sneha? Suppose the report shows that there is a anemia, but MCHC is normal.
Yes,
and RDW is low. How do you confirm thalassemia minor?
High performance HPLC liquid chromatography is a confirmatory test for the thalassemia, and Nestroft is screening test for the thalassemia.
So now we are away from Nestroff. Nestroff will typically show very clearly sickle cell anemia because HPLC will tell you about A0, A2 and S levels, and if there are any other like C and D hemoglobins, even that the HPLC will show you. And with this era where in all medical colleges also it is done, and in all the major labs it is done in all major cities, it should not be a problem, because as obstetricians it is our responsibility to ensure we don't produce second generation of thalassemia major children, isn't it? So it's our prime responsibility to screen them for thalassemia minor. How does anemia of chronic diseases look like? Very typical. All the indices will be low, like suppose anemia of CKD. It will be like this. Hemolytic anemia, you will see hemolytic fragment. Aplastic anemia, you will see low RBC count and low hemoglobin. But all the RBCs that are there, the indices will not be so much affected in aplastic anemia. Hemorrhagic anemia, again, if it is acute hemorrhage, then your all indices will be normal, because for a person who has had hemoglobin of 12, and then she has a PPH and of 6, and some tomorrow's hemoglobin is 6, but the indices will not be low, because in one day the indices cannot change, right? Of course, thalassemia, sickle cell, hemolytic, all we saw, and other hemoglobinopathies, and any kind of other inherited hemolytic anemias, we know how the picture will be of typical hemolytic anemia.
If there is pancytopenia, what does it indicate? Any type of anemia which can have a pancytopenia, Sneha?
In aplastic anemia, pancytopenia is seen.
Okay. And rarely, even with the megaloblastic anemia, you can have a low platelet and low WBC. Okay.
Go ahead, next.
Then on the final diagnosis is, for my case, is gravida to para1 live 1 with gestational age of 32 plus 2 weeks with single live fetus in cephalic presentation with moderate iron deficiency anemia. Moderate is 7.
So confirmatory iron deficiency anemia is with serum iron studies and total iron binding capacity. So you cannot just say that moderate anemia you can say, but iron deficiency you have to confirm. Of course, typically in India, in low socioeconomic status and with the whatever you have background, you have given clinical background, it looks like it is iron deficiency. Why do you think she has iron deficiency anemia? What supports your diagnosis?
Ma'am, as though her hemogram is suggestive of iron deficiency anemia, MCV, MCHC.
No, dear, you start with symptoms and her history. Investigation will only support your diagnosis, na?
Yes,
why do you think it is? Why do you think she has? She's got anemic in first place. Your history and clinical history and examination must have told you something, na? her socioeconomic status, whether she was booked, unbooked, whether she is going for regular antenatal visits, whether she's taking iron supplements, whether her duration between two pregnancies, her dietary history, everything should support your diagnosis, isn't it? So tell all the points.
Yes, ma'am. As she came with the complaints which were the easy fatigability since the 3 months, and there is on exertion she was feeling tired. Then again there was no history of bleeding or no history of other chest pain.
I gave you so many answers, no? That she's from low socioeconomic status,
Yes,
back-to-back pregnancies, did not take iron supplements. These are the reasons why she has landed into such bad kind of anemia. Yeah, go ahead.
On examination also she was pallor and
See, Neha, to justify the diagnosis, if you tell us what are the things which will take you towards the diagnosis, because on one side you are saying that she has got anemia, but does not have edema, does not have tachycardia, does not have any signs, and the fetal growth is also appears to be proper. For 32 weeks, you are saying 2 to 2.2 kgs, which also does not tally. And if she's got symptoms, signs and symptoms for so long, it has to show somewhere. So please justify how you have arrived at the diagnosis.
Sir, she was giving the complaints about which were suggestive of anemia. These are also seen in the cardiac diseases, but as the chest pain and other complaints was not there, so I concluded it could be anemia. And after she was pallor also, and after her complete hemogram, I conclude to the diagnosis of iron deficiency anemia.
What findings on cardiovascular examination will you find with somebody who has 7 gram hemoglobin? What are the findings of anemia in cardiovascular auscultation? Your auscultation was also normal, right?
Yes,
what sir is saying is right.
Tachycardia.
No, auscultation. Tachycardia you won't see on auscultation. No, you may see, but that's not the auscultation. There's something specific that you're looking at.
Loud S1 and S2 sounds or murmur can be present.
Yes, which kind of murmur?
Which murmur?
Sometimes in severe anemia, we get murmur also with the tachycardia, 100, 110.
Yes,
so that is because of what? Is it because of the heart lesions or is it because of something else? In severe anemia, we get that.
You can get a soft systolic murmur, hemic murmur, isn't it?
Yes.
So what sir is asking you, what is the cause?
Is there is hyperdynamic circulation in anemia and failure?
Yes, sir.
Okay. So we just want you to justify your diagnosis, Why are you saying that? Once we get the diagnosis, we go retrospectively. But now we want you to justify the diagnosis, apart from the investigations.
Okay.
Okay, one more thing you said about the thalassemia. Okay, if there is no history of thalassemia in the patient, there is no family history of thalassemia. How did you arrive at that diagnosis? That there is no history of the thalassemia in the family also. And which type of thalassemia? Alpha, beta, which one?
Sir, it is only by asking her about the history.
What is the history?
Is there anybody in the family who required serial blood transfusion, many blood transfusions in her family, in her siblings or?
So if the siblings have received repeated blood transfusions, that is 5, 10, 15, do you think so they will get pregnant and come at this stage?
No,
and
sir.
The anemia then?
No, sir.
No.
No, sir. Even she can tell about died because of the thalassemia. She might be known if there is any death because of the thalassemia in her family. She might be known. So she didn't give history like this.
No, what do you mean by family? Her sister, brother,
This is a sibling, sir.
sibling?
What will be the typical history in thalassemia minor, Sneha? How will you suspect that this is thalassemia minor? For example, your patient only, now she is 32 weeks and all these parameters are there. How will you suspect, at what stage in your treatment you will suspect that something is wrong and it might not be iron deficiency?
See, you've got one hint also. Madam has given you one hint.
I have given more than a single hint.
She is
At
very
what
compliant to
stage?
your iron tablet. She's taking your iron tablet, but what else you
What
want to
will
see?
happen?
Ma'am, I will.
How will you know that whether she is responding to your treatment? How will you know?
Yes, ma'am. After 4 weeks, I will, or after 3 to 4 weeks, I will repeat the hemogram again, and we'll see if
Before
she
that,
is.
there is nothing which will give you the clue whether she is responding or not. You have to wait for 3 to 4 weeks. Nothing before that.
Ma'am, reticulocytosis count can be seen within 1 week. After 5-6 days, it will get raised by 5%.
Symptom again, as madam said, go back to
Yes, ma'am.
symptom.
Feeling of well-being.
What? Yeah.
Yes, ma'am. Sense of well-being.
So if she is
and also
not
she can-
responder, if she is a non-responder, what are the various causes of patient remaining non-responder? What are the possibilities if patient is a non-responder?
Yes, ma'am. She can be a case of thalassemia then.
First,
Or other-
commonest for non-responder for iron treatment is non-compliance, isn't it?
Yes, ma'am.
After that, everything else comes. So then
Yes,
second, thalassemia also is again little rare. Second
Yes, ma'am.
most common is after non-compliance, malabsorption syndromes. Nowadays, post gastrectomy or bariatric surgery, they come.
Yes, ma'am.
Concomitant, what is happening to iron in tablets? Is she taking it correctly? Did you educate her how to take iron tablet?
Yes, ma'am.
Yes. So
Actually,
what is it?
we
What
have
are the factors which will not let the iron tablet work? What are the causes of non-responders?
What hampers the absorption?
First is not compliance. Then if she is taking the tablets after meal, so it will reduce the absorption. So counsel in proper way to how to take the iron tablets. Then
What else reduces absorption? Especially in pregnancy, we have to be very, very careful when we instruct the patient, counsel the patient when we are giving iron tablets.
Ma'am, the calcium, we also give the tablets of calcium. It should not be taken along with the ferrous sulfate or iron tablets. Then milk should be avoided.
Calcium will reduce, phytates will reduce, tea and
Phytates,
coffee.
tannins. Yes, ma'am.
In
Tannins,
rural
phytates.
areas, there is a
Milk
practice that along with the meals only they are consuming tea or coffee. So that
Yes,
will
yes,
also
ma'am.
reduce the absorption. What will improve the absorption when you are telling
Ma'am,
her to take the tablets?
if she is taking iron tablet with vitamin C, so advise her for the orange juice and the lime juice, and I advise properly to take 1 hour before the meal, to take iron tablets 1 hour before meal.
Sorry, judges. Sorry to interrupt you. We have 10 more minutes to wind up with this case.
Okay, thank you.
Then we will advise her to take apricot, jaggery, groundnut, then spinach, green leafy vegetables.
Okay, Neha, tell me one thing. If a known case of beta thalassemia comes to you, a pregnant lady, how will you prescribe the irons to her?
What is the problem with beta thalassemia major, Sneha? What is happening? If you think, you will know. Is there any hemolysis?
Yes, ma'am.
So what is happening because of hemolysis?
What is happening to iron metabolism?
Too much iron in the body.
Yes, ma'am.
So what will happen? That's what sir is asking. How will you prescribe iron? You can't randomly prescribe
Yes,
iron
ma'am.
for such people. What are they at risk of?
Increase the iron load. So
What is it called?
transferring
What is it called?
hemocytosis.
So how will you
We
prescribe
will
iron?
give. Yes, ma'am. We will give desferoxamine before
No,
the.
that is a big story that the hematologist has to do. But what will you do? What will you do before prescribing iron? Which should you prescribe or should you not prescribe?
Will depend on what?
Serum transferrin level.
Sickle cell trait, how will you decide? Same way, as sir is asking, same way, she is a sickle cell trait. How will you decide whether to give her iron or not?
By serum transferrin level.
Serum
Transferrin level.
transferrin. Is it transferrin level, Sneha?
No, ma'am.
Iron stores are depicted by which parameter? Serum iron, serum transferrin, serum ferritin.
Serum and T.
Huh? So you have to look at serum ferritin levels. And if they are high, that means there is some iron overload. You have to look for any problems of hemosiderosis, whether it is sitting in the heart, kidney, liver, whatever. That's a big evaluation that goes on after that. And she should not be on iron tablets. That much we have to remember. Okay, will you transfuse blood for this lady?
No, ma'am. As she was 32 plus 2 weeks, we gave her parenteral therapy, iron sucrose for 5 doses.
What are the indications of parenteral iron in obstetrics?
Ma'am, her hemoglobin. Okay. As her hemoglobin is 7.3.
Madam is asking in general, what are the indications for parenteral iron therapy?
Yes, ma'am. According to Ministry of Health and Family Welfare, that's if hemoglobin is between 5 to 8 gram%, then we should go for the parenteral therapy. MOS, Ministry of Health and Family Welfare, it suggests about the intramuscular iron therapy.
Intramuscular is not parenteral?
Yes, ma'am, it is parenteral.
So which route and all we will discuss later, whether to give IV or IM and all that.
Yes,
what are the indications? Tell me 1, 2, 3, 4, 5 indications of parenteral iron.
If it is non-compliant to the iron therapy, if she's feeling gastric upset with oral iron therapy, then if there is malabsorption, then if we have less time to see the response of the patient to the iron therapy, if the
less
patient
time
is
means less time means what? Less time is what, Sneha?
Yes, ma'am. If she is more than 32 weeks, and there are
Do you mean to say the rate of hemoglobin rise is more with parenteral
no,
as compared to oral?
No, ma'am. The rate is same, but compliance and bioavailability is good, and there is assurity of
How much you is expected hemoglobin rise? How much you will expect once you start the therapy, whether oral, injectable?
Within 2 to 3 weeks, there is first reticulocyte count increases, and then within 2 to 3 weeks, there is 0.8 gram raise in the hemoglobin, and with subsequent per week. So,
using within 2 to 3 weeks. So
yes, sir.
For 2 to 3 weeks.
Sorry,
when is the response that you get?
Sorry, sir, I didn't get the
question. After how many days?
After 3 to 4 weeks. We will repeat the hemogram to see if there is a response to the iron therapy or not.
Neha, we can't wait for that long. No, in pregnancy, we are racing against time. After 2 to 3 weeks, she'll be 35, 36 weeks, isn't it? She's 32 plus weeks already.
And further reduction in hemoglobin will be there with the fetal increasing.
As the pregnancy advances, yes.
She will
So
go
what
for
will you do?
severe.
Sir is asking you, how will you look for response, immediate response? Something will be seen.
There is feeling of well-being in the patient. She can do her activities regularly. With, these are the immediate responses.
Did she come with breathlessness and fatigability
Yes,
and
ma'am.
whatever your symptoms
ma'am.
in the
There is-
first slide that you said? So what will happen to them?
feeling of well-being, sense of well-being.
Judges, we
What are
have
indications
2
for blood
minutes. Can you please
transfusion?
conclude the
You can
case?
see, yeah.
Sure.
What are
How
the
will you
indications?
calculate the iron requirement?
Yes, ma'am. According to Foxy guidelines, it is 2.4 into pre-pregnancy weight into target HB minus present HB plus 1000 milligram. For
What
the
is your
iron.
target HB?
11, ma'am.
Very low target, no? 12. Keep your
No,
target
target
12.
is 14. 1,
Ah,
4,
14.
Sneha. Target is
Yeah.
14, not 11. What
So
are the
whose
indications
formula
for
is
blood
it?
transfusion in pregnancy?
What is it
In
called?
anemia?
Whose formula?
Ma'am, it is given by Foxy recommendation.
Ganzoni equation.
Okay.
Neha,
Indications for blood transfusion, you tell us, Sneha, in
Ma'am,
case
if
of anemia.
Ma'am, yes, ma'am. If the patient is more than 36 weeks, then we should transfuse blood if hemoglobin is less than 5 gram per set according to WHO. And if hemoglobin is 5 to 7 gram per cent, and if there is any sign of cardiac failure, pneumonia, or any other any other infection, we should go for the blood transfusion. In less than 36 weeks, less than 32 weeks, if hemoglobin is less than 5, we should go for the blood transfusion, and if 5 to 7, we can give her parenteral therapy.
What about postpartum state?
Ma'am, according to Ministry of Health and Family Welfare, 100 milligram of elemental iron with 500 microgram.
No, in your IV, in your blood transfusion, postpartum state you have not mentioning.
Okay, ma'am.
Suppose she had a major PPH and she major obstetric hemorrhage and she is you can't discharge her in that state, right? Because it's an acute hemorrhage. This lady with 7 gram hemoglobin is tolerating the anemia very well because it's a chronic state for her. But for a woman who had 12 and had major obstetric hemorrhage, she won't tolerate hemoglobin of 6 and 7 in postpartum period, right? Yes.
10 in postpartum period.
Yes. Okay, if she comes in labor in one breath and one sentence, if she comes in labor, she did not take your IV iron, her hemoglobin was 6 gram per cent and she's landed in labor at 38 weeks.
Yes, ma'am. Immediately issue 1 point PRC, 1 point blood, and it should be transfused.
My dear Sneha, examine her, how advanced in labor it is. She is put 2 IV lines, start
Yes, ma'am.
cartogram, give her pain
And,
relief because
oxygen.
tachycardia is not good for her. Oxygen.
Yes, ma'am. Oxygen requirement, then analgesic
you are
should be
talking
in
as if
hand,
just
and oxytocin.
we can't just prescribe 1 pint of blood and then go and sleep, na? Other things also we have to do. Yes, please.
Prophylactic antibiotic.
Antibiotic has to
Oxytocin
be
should
given.
be in hand. Yes, ma'am. Oxygen is given if it is required. Then
Will you alert blood bank?
avoid
Will you
the
alert
restrict the
anesthetist?
IV
Have 2
fluids.
wide bore IV lines.
Yes, ma'am. And
Yes.
restrict IV fluids. Then in the
She
second
won't
stage of
blood loss also.
yes, ma'am.
You need to be ready.
Yes, ma'am. In the second stage of labor, assisted vaginal delivery might be required. We should avoid the episiotomy and prophylactic
Why assisted
antibiotics
vaginal delivery will be required?
to shorten the second stage of labor.
Okay, yeah.
And in the third stage of labor, the active management stage of labor should be given. That is 10 units of the pitocin.
Neha, tell me one thing. If she's B negative and you don't have blood and she's 6 grams per cent, what will you do?
O negative.
6 grams.
If O negative blood is available, or
That is also not.
Judges, can we please conclude it in a minute? We are overboarding the time. Can you please conclude in a
Last
minute?
question. This is last question. She has to fire now. There's no blood.
No, sir. Sorry.
You want to answer? Okay, we can conclude.
Have you heard of cell salvage, Sneha?
Yes, ma'am.
Red cell salvage? Have you heard of red cell salvage?
No, ma'am.
Auto transfusion, autologous transfusion, heard of cell salvage? All these will be, you will read it up in the literature.
Yes,
That gives
ma'am.
answer to Sir's question.
Yes, ma'am.
So I think we should conclude. Anjali ma'am and Deshmukh sir.
To
Yeah,
conclude, I
Manisha
think
ma'am.
that I think we should be more
Could you
aware
please
about
conclude
how
the
to do
case?
the primary prevention to conclude, and with the
Summarize
anemia,
for the
Mukta
students.
Bharat, and with the Iron Plus initiative, at least 2 decades later, we obstetricians should be facing less and less situations where patient is in labor, 5 gram. That is the hope we can have. But for Sneha, for you, you should not jump to investigations is my advice. Whenever you think about the patient, start with the symptoms,
Yes, ma'am.
signs, and then only when your clinical picture should be very clear, clinical diagnosis should be clear. You can have a differential diagnosis and then go for the investigations. Well presented.
Thank you.
Yes, well presented, Sneha, but you need to read up some literature.
Yes, ma'am.
Otherwise, it was very well presented. And I agree with what Dr. Anjali says. You need to be very organized in your thoughts. Start from clinical history examination and then go to investigations whenever any question is asked, and answer to the point when
Yes,
we are
ma'am.
asking you some questions.
And as a Neha, what we do as a resident, we keep the diagnosis in our mind and then we
Yes.
revolve around the diagnosis. But when you practice, you don't get the diagnosis. You have to find out the diagnosis.
Yes.
That is the difference. Here you had the diagnosis and you are trying to go around the diagnosis. So you just leave the diagnosis and it becomes difficult for you.
So for all the students over there, it is said the more you grill a chicken, the tastier it becomes. So take this case discussion as an opportunity to become a better obstetrician ahead. So thank you, judges. Thank you, Deshmukh sir. Thank you, Kothulkar ma'am. Thank you, Anisha ma'am. Thank you.
Thank you very much.
So we
Thank you,
move
ma'am.
to our
Thank you
next,
very much.
Thank you.
Thank you, madam.
Thank you.
Thank you. Thank you, everybody.
We move to our next session. It will be another case discussion by Dr. Shivangi Joshi on the topic primary infertility. For our next case discussion, we have the eminent faculty from the various prestigious institutes, Dr. Reena Vani ma'am, Dr. Dipti Srivastava ma'am, and Dr. Kanchan ma'am. We welcome you all. Dr. Reena Vani ma'am, she is a FOXY member for COVID guidance and vaccination. She is President, Mumbai Breastfeeding Promotion Committee 2019 to 2022. She is a gold medalist, distinction holder, and a prize and various award winner. She is a co-editor of 14 books and author of 2 textbooks. And yes, obviously, she is a great UG PG teacher since many years. We welcome you, ma'am. Next, we have with us Dr. Dipti Srivastava ma'am. Ma'am, are you there? Okay, we'll be joining in a while. We'll introduce you.
Actually, I am traveling.
Welcome, ma'am. She is a past president of Delhi to her credit, and she is a award winner, and she has many paper and poster presentations in her credit. Welcome, ma'am. Next faculty member, we have Dr. Kanchan Vidmuthe, ma'am. She is assistant professor at NKP SIMS LMH Nagpur. She has a huge UG and PG teaching experience. She is also BLSO and BLS instructor. She has many national and international publications. Welcome, ma'am. Shivangi, you can start presenting. All the best. You can start sharing your screen. Yes, ma'am.
Shivangi, can you hear us? I think Shivangi is muted.
Shivangi, can you unmute yourself and start sharing the screen? Shivangi, unmute yourself. Call her.
So while we're getting the technology going, there's a saying, the
Welcome,
students,
Dipti ma'am.
technology is
Good
more.
afternoon, ma'am.
Yes, Shivangi, will just give me a minute. Since
Yes.
while we are getting your technology going, what I wanted to tell the students is that technology is not about speed, but it's more about the direction. So use the technology you guys have at your hand wisely, and let's take the next I think for 20 minutes or so to usefully use the technology. Yeah, Shivangi, over to you. Please start.
Good afternoon, ma'am. My topic for today is primary infertility. A 25-year-old Mrs. ABC, resident of Nagpur, housewife, 12th pass, Hindu by religion, belonging to low middle class, came to OPD with her husband, who is 28-year-old graduate, salesman by occupation, with complaint of inability to conceive in spite of trying since last 4 years. History of present illness. Patient gives history of inability to conceive in spite of regular unprotected intercourse since last 4 years. There is no history of menstrual irregularity, no history of weight gain, no history of excessive facial hair growth or acne, no history of pain in lower abdomen or mass in abdomen, no history of burning, micturition, backache, no history of vaginal discharge, itching over perineal region, no history of intermenstrual bleeding, no postcoital bleeding, no history of cold intolerance or hair loss, no history of decreased sexual drive, no history of nipple discharge, no history of chronic cough, weight loss, or evening rise of temperature, no history of multiple sexual partners. Husband's history, there is no history of multiple.
Hold on. Now, in this history, 80% of your diagnosis is going to be based on a proper history. You have given a lot of negative history, but what is one important history which you should give about the intercourse? You said regular unprotected intercourse. So define what is regular intercourse and what do you think should be the frequency of intercourse in a average married couple that you expect them to get pregnant? What would be the advice if the couple asks you?
Ma'am, regular unprotected intercourse is more than 3 times in a week.
Give me a reference for this.
Ma'am, spare off.
So for getting pregnant, a lot of studies have been done. And they have said that intercourse up to 2 to 3 times a week also. In fact, in Latin America, contraception studies showed that average married couples don't use more than 72 condoms in a year. But when you talk about frequency of intercourse, 2 to 3 times a week is adequate to get pregnant, of course, because now we don't have a very long time, but the longevity of the ovum and the sperm, you have to keep in mind. Hence, in your history, before you give so much of negative history, you should have mentioned that the unprotected intercourse, how many times in a week is also important, because nowadays with technology and this, I have young couples who come to me saying that they don't manage to make love more than once a week. Sometimes it's even less frequent than that because of other issues. So this is important in your history. And another thing is history of dyspareunia. What is the importance of asking for dyspareunia in a couple who's trying to get pregnant?
History of dyspareunia, it can be a regional cause. There can be some vaginal cyst, Bartholin cyst, or there can be endometriosis also, which can lead to dyspareunia.
Yeah, so first of all, talk about common things first. Now, a Bartholin cyst or a Gartner's duct cyst or anything would be very uncommon. So dyspareunia can be just a simple such thing like vaginitis, which is again leading to a problem with the cervical or vaginal factor, leading to problems with getting pregnant. And of course, dyspareunia can be due to other conditions in which even PCOD with bulky ovaries, deep dyspareunia is one of the symptoms. And in endometriosis, what kind of dyspareunia is described? What is the reason for dyspareunia?
Chronic infection will lead to adhesions, and there is impaired
No, I'm
mobility.
talking about endometriosis, not chronic PID. In endometriosis, what is the association with dyspareunia? Endometriosis is not an infective pathology. So typically they say that endometriotic nodules, if they are present in the pouch of Douglas or the uterosacrals, can in fact leads to dyspareunia. And another thing is there is scarring or puckering in that region. So these are the various factors associated with dyspareunia. So that also was important. Okay, continue.
Husband's history, there is no history of multiple sexual partners. There is no history of decreased sexual drive, no history of polyuria, polydipsia, no history of sparse axillary or pubic hair, no history of undescended testes, testicular trauma, no history of scrotal swelling, no history of urinary complaints, no history of erectile dysfunction or ejaculatory problem, no history of use of any medication or drugs, no history of addiction. Menstrual history, patient attended menarche at 13 years of age. Previous menstrual cycles were regular with an interval of 28 to 30 days for 4 to 5 days duration, soakage of 2 to 3 pads per day, associated with mild pain in lower abdomen. There was no history of passage of clots. Her last menstrual period was 8th of February 2021. Obstetric history, married since 4 years, non-consanguineous marriage, patient is living with her husband and she is nulli gravida. Coital history of coitus.
So one comment I would like to mention here that you are taking a lot of negative histories. So this is obviously getting something abnormal in presentation of yours. And as the madam said that rightly, that history of consummation of marriage is very important. So sometimes due to other factors which we have discussed, the functional factors are also there. So you have to find out the vaginismus or some other functional factors. So many couples, they come after even 2-3 years of marriage where the consummation of marriage is not done even. So this has to be asked, and if you are finding everything is normal, you should simply mention that this is normal and not need not to saying that this is negative, this is negative, this is negative. So this is my opinion.
Yeah, I actually agree with madam here that what Dr. Dipti is saying, that too much of negative history is not always useful. And in fact, in the husband's history, important negative history, like for example, smoking, exposure to heat or chemicals, or these things are also important, or any surgery like hernia or undescended testes, or like in childhood they've had a hydrocele or hernia surgery. These are important negative histories, but you need not give so much of negative history in various aspects. Yes, yes ma'am, continue.
Coital history, there is history of coitus 4 to 6 times in a week, no history of contraceptive use, no history of use of lubricant, there is no history of postcoital douching, no history of incomplete penetration or premature ejaculation, there is no history of dyspareunia, patient is aware of her fertility window. Past history of acute onset pain in lower abdomen 3 years back, which was dull aching radiating to lower back, aggravated with coitus, which lasted for 4 to 5 days, which was associated with fever, continuous in nature, relieved with medication, and not associated with chills and rigor. There was history of discharge per vaginum associated with this pain, which was yellowish white, mucopurulent, foul smelling. Patient had visited a clinic where couple was given medication which they took for 7 days, and later they were not compliant with their treatment. 3 to 4 months later, she had similar complaint for which she visited a clinic again and was prescribed medication for 14 days, which she took completely. There is no history of diabetes, hypertension, thyroid disorder, sickle cell anemia, blood transfusion, tuberculosis. There is no history of surgery in the past. Family history, there is no history of diabetes, mellitus, hypertension, thyroid disorders, tuberculosis, or anemia in the family. No history of infertility in the family. No history of early menopause in the family. Personal history, patient takes mixed diet, good appetite, adequate sleep, normal bowel and bladder habits. There is no history of addiction, drug abuse in both the partners. Summary, a 25-year-old nulli gravida, primary infertility of 4 years, probably due to pelvic inflammatory disease in the past.
Shivangi, what is the association of pelvic inflammatory disease with infertility? In what way?
Ma'am, pelvic inflammatory disease can lead to tubal cause of infertility, It can hamper tubal motility. It can have defective endometrium, so it can lead to infertility.
But you are talking here that patient had 2 episodes of proper mucopurulent discharge. Now, what is the, in fact, what is the syndromic management of infection, vaginal discharge? WHO has described this syndromic management.
We give syndromic management is of infertility. Here we will give, there are color-coded kits available according to the infection. This is given, and we treat both the partners. Here we can give doxycycline and metronidazole for 14 days along with 1 tablet of azithromycin.
Now, in this patient, if you're assuming that she has had, what you have to remember is bacterial salpingitis. It has been suggested that 1 attack of gonococcal salpingitis can lead to up to 15% tubal block, 2 episodes, 25%, and 3 or more untreated episodes can lead to 75% of the women getting tubal block. But what about tubercular salpingitis? When you're talking about pelvic inflammatory disease, do you think your history, in all the negative histories you mentioned, did you have anything specific which ruled out tuberculosis or COX contact?
There was no history of evening rise of temperature, weight loss, and there was no history of COX in the past, and there was no family history of COX.
Do you think these are enough to rule out? What is the incidence of tuberculosis as a contributor to infertility in our country?
10 to 15%.
Yeah, up to 15%. There may be a contribution of tuberculosis as one of the factors which is leading to infertility. Yes. Dr. Kanchan, would you like to ask something?
How will you proceed with your case?
Sorry, ma'am.
How will you proceed with your case?
Ma'am, with the general physical examination, patient is moderate build, well nourished. Her BMI is 22.5, waist circumference is 72 centimeter, pulse is 86 beats per minute regular, blood pressure is 120 by 80 millimeters of mercury in left arm in sitting position. Her respiratory rate is 12 per minute. Patient is afebrile. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema of feet. Her thyroid and breast examination is normal. Spine is normal. Her systemic examination is also normal. On per abdominal
breast examination, you should mention that there is no discharge from the nipple. Normal?
Yes, ma'am.
In breast examination?
Yes, ma'am.
What is the significance of galactoria? Because in fact, breast examination is something every gynecologist should do, not only in your infertility case, each and every case you need to mention breast examination. So in this case, as madam pointed out, you are to look for...
In case of infertility, hyperprolactinemia is associated with infertility. So we need to rule out that. And one of the signs of hyperprolactinemia is galactoria.
Yeah, so actually only 1/3 of patients with hyperprolactinemia may have galactoria, but breast discharge can also be a sign of one other hormonal imbalance other than prolactin. What else? Sometimes even with thyroid dysfunction, because yes, with thyroid dysfunction also you may get breast discharge. So in both of these, but what is usually the typical association with the period pattern? Your patient did not have it, but in a particular type of period pattern, you have to do a breast examination. What is that period pattern? So indirectly, I'm asking you, what is the effect
anovulatory cycles?
Irregular, scanty, or delayed periods could be associated with thyroid or prolactin abnormalities. So in those, you must look for discharge, which is a sign of hormonal disturbance. Yeah. Now here you talked about her BMI, and what is the definition of normal BMI for our country now?
For our country, it is 18.5 to 23 is considered as normal BMI. And 23 to 25 is overweight. More than 25 is obesity for India.
Okay. Yeah, continue.
On per abdominal examination, on inspection, abdomen contour is normal, umbilicus is central, inverted, no evidence of scar, lump, or engorged veins. Hernial orifices are intact. On palpation, abdomen is soft, non-tender, no evidence of organomegaly. On percussion, there is no evidence of free fluid. On auscultation, vowel sounds are normal. On vaginal examination inspection, external genitalia is normal. There is no evidence of discharge, any lesion, ulcer, or swelling. On speculum examination, vaginal mucosa appears healthy, no discharge. Cervix is pink color, external or pinpoint, thick cervical mucus present, and there is no bleeding on touch. On vaginal examination, uterus is normal size, anteverted mid place, freely mobile, non-tender, no adnexal mass palpable.
What day of cycle was this lady when you examined her? You gave her LMP, right? So
yes, ma'am. It was day 20 of cycle.
it was day
20.
Day 20. Okay. What is the cervical? Is there any cervical scoring system you are aware of? And does the cervical mucus examination help you in this kind of a case?
Ma'am, if it is day 22 of the cycle, so ovulation has already occurred. So cervical mucus will be thick. Before in periovulatory phase, it will be thin.
But my question was, are you aware of any cervical scoring system which is used in infertility or for categorizing the cervical?
There is one 4-point cervical scoring system is there.
There is a book on the name of that scoring system also.
Yeah, madam is giving you a nice
book. Have you heard ever about Insler?
Insler score, yes.
What is spin Barkit? What does the word spin Barkit tell you?
Ma'am, spin Barkit, it is cervical mucus when we take on a slide and stretch it. There is that thin cervical mucoid discharge. It gets stretched and that is known as spin Barkit.
So this is spin Barkit and furning are two of the viscous properties of the cervical mucus under the influence of estrogen. And spin Barkit is the stretchability, not necessarily only on the slide. Even if from you take a swab from the mouth of the cervix and this, you'll find that the cervical mucus is stretching out and very stretchable and long in cases when there is a good estrogen influence. So the 4 points of that cervical scoring system are something which were used a lot. And along with that, one other test called PCT. What was that test?
Postcoital test.
So if this patient had told you that I had had intercourse last night, would it have been helpful to do this test in this patient?
No, ma'am. She's already day 20 of her menstruation. So we can just see the whether the sperm, there is any.
No, but a postcoital test, yes, ideally you would like to do it around the time of ovulation, but she is still in that phase. It could be sometime. So you can't say that you won't want to do the postcoital test. If it is useful, it could be done even at this phase of the cycle. Yes, other examiners, what is your opinion?
Yes,
ma'am,
Shivangi, the postcoital test, I would like to ask you how many times you have performed this test? Never. So nowadays it is not practiced. Previously it was very common to be done because of the male factor problem, social problem of the male factor investigation. Usually the male partners do not wish to come to the OPD for any fertility workup. So this is especially helpful if you take the mucus from the posterior fornix and you see the relationship of the cervical mucus with the sperm, whether they are having the good penetration of the cervical mucus or not. And at the same time, you can assess the semen parameters of the male partner. So nowadays, we rarely do this test, but it is helpful nowadays to find out whether any sperm antibodies are there. So if any sperm antibodies are there in like a female partner against the sperms, then you may find the test really useful. But otherwise, we have got presently there are so many sperm function tests and all, and male partners are also nowadays aware and they are coming to the OPD. So that's why it is less common in the practice. But you must be knowing what is this test and other synonym of the test, and theoretically and historically how it is important.
Yes, I think, yeah. Continue with your.
So my provisional diagnosis is 24-year-old female with primary infertility of 4 years, probably due to tubal factor.
Do you
How
all?
you will,
Yeah, it's a little difficult to say that tubal factor based on, yes.
you cannot
On
make
what basis?
diagnosis, yes,
Yeah.
on the basis of history. So I would like to ask you, any time if any patient or any couple is coming to you, first time at your OPD for infertility workup, how will you proceed? What are the, I would like to simply enumerate you the 3 basic tests for investigation of infertility in the couple. If she is, suppose she is coming on a day 2 of a cycle, she is on day 20 of cycle, but if she comes on day 2 of a cycle, what you should remember that what are the 3 basic investigation which give you more than 60% idea about the pathology.
First, we will ask about the history of the patient, whether she has regular menses and whether it is associated with pain. So that first gives a history of that ovulatory
History
cycle.
part is already over. Now you are coming to the management. Okay. So management
Shivangi,
include
remember when the
investigation and
examiner,
treatment.
Madam has asked you a very specific question. She has said, name 3 tests which are required for this lady or this couple. So
First,
don't
semen analysis. Second, serum FSH plus estradiol level. And normally we do TSH and levels.
See, FSH and LH are good to be done, but nowadays the more informative test is what?
Serum
AMH.
AMH levels.
And third thing should be the AFC.
USG.
AFC is what?
Antral
Can you
follicular
mention something
count.
about? So how it is to be done?
Antral follicular count, it is USG, it is done from day 9 on of the menses, and here we see the size of the antral follicle and total count. If it is less than,
AFC is done on day 9 of the cycle.
So you have to be clear about it. So for female partners, in spite of if it is asked you to enumerate 3 basic tests, you have to answer first is yes, husband semen analysis. Second is AMH and AFC, and third is because she is giving history of PID, so you cannot directly post her for the HSC, but you have to find out the tubal factor for her. So you have to plan the either diagnostic hysterolaparoscopy for her once you are finding that she is in a non-infective state, or HSG if you find she is very clean cut case, USG is not suggestive of any mass or anything, or TB is there is no possibility of having the tuberculosis, so you shouldn't be flaring up any infection by doing the HSG. But otherwise, as a basic, you have to plan the patient for the HSG as well. So what are the ideal days when you should do the HSG for a patient?
in the post-menstrual phase, immediately we can do it from day 5 to day 10.
Day 5 to day 10. Yes, before day 10. So it comes day 6, 7, 8, 9. So these 4 days are important for doing the HSG. How to perform HSG?
We have it is we push a contrast, that is iohexol contrast 10 to 15 ml, and 2 X-ray films are taken.
So
First,
this comes in a ampule of only 10 ml. So you have to ask for the two vial of the iohexol. Have you ever done the HSG?
What is the capacity of the uterine cavity?
10 to 12 ml, 10 to 15.
Not really. The usual uterine cavity is not more than 1.5 to 5 ml is the maximum capacity of the uterine cavity itself. No, but before we go into HSG, Dr. Deepti, I just want to clarify. she had talked about the basic tests which have to be done. Now here, you mentioned something about FSH and estradiol. Honestly, almost nobody does these tests unless even for PCOD. Now we really don't require to do all these tests. If at all you would talk about any hormonal test. Now here, your lady had regular cycles. You are not suspecting anovulation and all is fine. If at all I would do any hormonal test, it would be the mid-luteal serum progesterone to document that whether she's ovulating or not. Other than that, I would not want to waste her money on any of these hormonal advanced tests. AMH, yes, it has a role now to get an idea of what is the capacity. Coming back to HSG, there's a lot of debate on HSG versus endoscopy. So now you are a consultant, patient has come to you. She's saying, "Ki, doctor, which of the two should I do?" She's suspecting tubal factor. And as Dr. Dipti pointed out, clinically and by ultrasound, you don't think she's in any acute phase. So you have these two options in front of you. Which one will you choose? And what is the information? And what is how will you choose for the patient? What are the points?
Ma'am, diagnostic hysterolaparoscopy would be a better option, and then HSG, because patient has we are suspecting infective etiology. So
no, now this is a question which you have to take in 2 or 3 points of view. One thing is scientifically, what is the extra information you're getting from that procedure? What
extra information we can see about the uterus adnexa can be visualized, and in the same setting we can see whether the tubes are patent or not, and with hysteroscopy we can see the endometrium, whether there are any other cause, and if there is any blockage, that can be operated in the same setting.
So basically in a hysterolaparoscopy, you're getting not just tubal and uterine factor, you are also getting the peritoneal factor, and the pelvis is being evaluated. And as you rightly said, you have the option of operative. But what are when I'm saying risks versus benefits, you need to put that in a scientific way. So what are the risks?
HSG is less costly. The other is costly. Here, HSG is a outpatient procedure. Diagnostic hysterolaparoscopy is a daycare procedure. Anesthetic complications can be there, but HSG has with HSG only structural defect can be seen, and with diagnostic hysterolaparoscopy we can see and operate at the same time.
So the advantage is, yes, you can do operative. With the HSG, one thing is, of course, you're avoiding risks of surgery and risks of anesthesia. Plus, you're getting a permanent record or a plate which can give you the idea of what is happening. Another thing, tubal spasm can occur both in HSG, and also you can have intravasation of dye or other things in laparoscopy also. So these are things which can happen in both. So yes, you're not wrong that in most situations, most gynecologists and patients will choose the laparoscopic approach with chromoperturbation is the correct word. But there are certain advantages of HSG, particularly for documentation. And the patient will ask you, doctor, isse mera kuch fayda hoga kya? Is my chance of pregnancy increased by this?
HSG, yes, sometimes a tubal block can be, with the pushing of dye, it gets relieved. So patient can conceive after HSG as well.
Well, it's not meant to be therapeutic, but there are some anecdotal reports that movement of the debris, which can happen both with your laparoscopic chromoperturbation or even with the HSG. And in fact, in laparoscopy, you also do what is known as, what is done for suspected proximal tubal block on laparoscopy nowadays? Cornual cannulation. You have a guide wire with which, it's a very basic procedure. A cornual cannulation can remove it's a not such a major thing, but it can help to bypass proximal cornual blocks.
Sorry, Jess. We have last 10 minutes for a session to get over.
Okay, so Shivangi, how will you go ahead with the management? So one thing is investigation part, where you already narrated every
Counseling of the
endocrine.
patient
Yes.
regarding her problem, and we will start folic acid supplementation for this patient. We will explain her regarding next investigations to be done and the plan of management. In investigations as described, we can go for her basic investigations, rule out hypothyroidism, rule out deranged blood sugar levels, then see her antral follicular count, then and plan her for diagnostic histolaparoscopy.
So we have done a diagnostic histolaparoscopy in this patient, and it showed. So okay, let's give you a situation where she has had a diagnostic histolap. The tube was showing some amount of block, but after you're pushing the dye and this, it is now patent. Now, what is the way forward?
We will ask the patient. We will first wait for next 6 months whether the patient conceives on her own. If not, we can go ahead with ovulation induction agent.
Would you really like to wait for 6 months?
Yeah. Why
or you will do something?
Yes, ma'am.
Why are
She's
you saying
already
wait for 6 months?
Yes.
6 months for what?
She is already 4 years married.
And it
So
was
after
not
scope, you
tubal
find
factor.
out that
See, here, if it was a tubal factor which you have corrected, it's a different thing. But here we are saying that the tubes were patent and she's already been trying for a while. So do you think it's worth waiting for 6 months after you've done the laparoscopy? Maybe
most
one
common
or two
cause of
cycles.
female infertility is what? Most common cause of female infertility. You must be knowing all the factors. I think you must be knowing how to evaluate all the factors of female infertility, starting from peritoneal factor, tubal factor, uterine factor, cervical factor, vaginal factor. So all these factors you have to evaluate. Peritoneal factor, you already did the endoscopy, laparoscopy, you are saying everything is normal. Tubal factor is you are like lucky to open up the tubes. Now uterine factor also you are saying all good. So what next? And other way, I would like to ask you, what is the most common cause of infertility, female infertility? Husband factor is also normal. Now what next? Why you are waiting for 6 months? So always remember, this is the anovulation, which is the most important factor. You can at least monitor her follicles in those 6 months if the patient is not willing. But from your own, you shouldn't be advising to wait for 6 months. So you have to vigorously monitoring her follicular factor, doing the follicular study, monitoring that whether she is really ovulating or not. Sometimes there are changes in the endometrium, and every endocrinal changes are suggestive of luteinization, but actually there is a entrapment of the follicle oocyte inside the luteinized follicle. So you have to see by confirmation whether she is ovulating or not. Or in other way, you can induce the ovulation to her. If you are finding any difficulty, suppose in 1-2 cycle you are finding she is not ovulating, so you have to induce her. So start from ovulation induction. What are the different drugs you will start with?
We can start with clomiphene citrate. We can give
oral ovulogen. What are different oral ovulogen? Because time is less, you should narrate in a summary what are different oral ovulogen, how they are different, and to whom you will prescribe what.
We can start with clomiphene citrate. We can give letrozole. We can give.
So what is the difference between clomiphene and letrozole?
Clomiphene citrate, it is estrogen receptor, selective estrogen receptor modulator, and clomiphene citrate, it is started as 50 milligram dose. We can start with for from day 5 to day from day 5 of menses, and for 5 days we can give 3 cycles of clomiphene citrate and monitor her ovulation by folliculometry, and
What I would like to ask you, difference between mechanism of action of letrozole versus clomiphene. Which drug you consider superior?
Now, letrozole is considered superior to clomiphene
Why?
citrate because ovarian hyperstimulation is less with letrozole.
So start from mechanism. That is what I want to know from you.
Letrozole, it acts by inhibiting the.
If you don't know, it's okay.
Shivangi, what was
proceed
it
further.
used for?
Aromatase
Letrozole?
inhibitor, and it decreases estrogen levels. So FSH levels. It inhibits the negative feedback on GnRH, so FSH levels will rise. Her own FSH levels will rise, which will result in increase in estrogen level.
So letrozole was introduced in gynecology for what originally? It's used in the hormonal treatment of breast cancer, which is why there was a lot of issue and there was withdrawal of the drug from the market in between when it was being used for ovulation induction. But now it is, of course, again got approved recently. What is the important effect on the endometrium, which is different in letrozole and clomiphene? Why in the problem with clomiphene, you should realize it's a good drug, it causes induction, but the pregnancy rate is probably half or less than that of the ovulation rate. And this is because of the anti-estrogenic effect of clomiphene at the endometrial level, and you often get a thin endometrium and you don't get the typical triple layer which you expect to have if you want to have a higher chance of getting pregnant. So in fact, in patients who don't respond to clomiphene, or after 3 cycles of clomiphene or more, or the endometrium is coming persistently thin when you are doing the monitoring, these are patients where you should opt to go for letrozole. A lot of people also take letrozole as the primary choice for ovulation induction now, but if you go through the guidelines of use of letrozole, originally it was described that it is to be used for patients who are resistant to clomiphene. So these are few things when you're reading about oral ovulation induction drugs, which is what is expected from you at a basic case, you should know all this. Yeah. So
after 3 cycles, she is not able to conceive with letrozole or clomiphene, whatever you are giving. What next you will advise her? You did laparoscopy, 3 cycles, you waited for oral ovulogen to act. Now what next?
We can give 3 more cycles, ma'am. Maximum 6 cycles can be given.
What is your opinion about IUI? What do you know about IUI?
Because after failed ovulation induction, we can go for IUI, and for
With failed ovulation induction, IUI will not work.
No, sorry. IUI, it is intrauterine insemination, and here it is done for male factor infertility and cervical factor of infertility.
And very important indication is unexplained infertility.
Unexplained infertility.
So here this is a sort of unexplained infertility, or you are suspicious about the delayed tubal spillage as well. So how it will take care of this? Okay, if you don't know, just go ahead.
So Shivangi, what madam is trying to tell you is that up to 10% of cases of infertility can be unexplained, where everything has failed. Now you have gone through, what is the, why have you set this limit of 6 cycles of clomiphene? What are the risks of continuing? Previously, people used to continue using clomiphene for up to a year or even more. Why has this stopped? And why do we now say there is a lifetime risk? In fact, they say up to maximum, some people say 9 cycles total. But why not more than that for ovulation induction? What are we concerned about?
Hyperstimulation, ovarian hyperstimulation.
No, my dear. This is long-term concerns, and that is why. What is the long-term concern?
Yeah, Shivangi, long. It
Vani
increases
ma'am, last 2 minutes, could you please summarize the case for the students?
Okay, Shivangi, so it will increase the risk of cancers. Which cancers?
CA endometrium.
No, my dear. Remember the whole idea, we are talking about ovulation induction, and the marker CA125 was discovered by Bast et al. Because of incessant ovulation. And there was an increased incidence of granulosa cell tumors, or these tumors were described in women who had undergone prolonged episodes of ovulation induction, which is what raised the concern. So anyway, but now that is a separate topic. Since we have only 2 minutes, as the organizers have asked us to summarize the case, Shivangi, can you just tell us the key points of the case now, what we have discussed so far? And what is the take-home message from this case?
Take-home message is that first evaluate the patient based on their history, then rule out what type of cause can be there. Accordingly, streamline your investigations and further management for the patient.
So I feel in your case, what you've pointed out nicely is that the thing was, as we discussed, there's a lot of negative history, but the important negative history you should highlight. You have evaluated the partner, given coital history, that is all important in an infertility case. A suspicion of tubal factor is what you could say based on the past history, which is why you have directed your investigations more in favor of investigating for tubal factor. And here, since we summarized that tubal factor was investigated and it did not find anything, then the next step forward is closely monitoring and doing ovulation induction. And if that also doesn't work and she goes into what we would label as unexplained infertility, then you would refer her to for further assisted reproductive technology. So that is, that's the way forward. And the role of AMH in investigations is now becoming more important. And I think what all of you need to read up, students, is read up appearances and importance of hysterosalpingogram, a comparison with laparoscopy, and also know a little bit more about cervical scoring and other systems, which are also important when you're answering further questions. Dr. Kanchan, tumhala kai key points, would you like to give a few points before we close?
I want to ask one question, Shivangi. What is PGD? What is PGD and PGS? Shivangi?
Yes, ma'am.
PGD? Pre-implantation genetic diagnosis. And there is second terminology, that is PGS, that is pre-implantation genetic screening. So what is PGD? You know that? So in
Pre-implantation
pre-implantation genetic
diagnosis, we screen for 4 things: trisomy 18, monosomy X, trisomy 13, and trisomy 21.
So in PGD, we are doing the genotype, and in PGS, that is screening, we are doing the karyotype, and we are screening for the aneuploidies. So thank you. Amruta, that's all, I think.
Amidst rising number of infertility cases, I think so this case-based learning on infertility topic not only helps students in clearing out their exams, but as a budding obstetrician for us, today's discussion would be helping us in putting theory into practical thing. I would like to give my thanks to Vani ma'am for sparing her valuable time and chairing this session and helping our students. A special thanks to Dipti ma'am. While traveling, she could log in and help us out. And thank you, Kanchan ma'am. And thank you, Shivangi. So
thank you and all the best to the students. And I think, Shivangi, we are passing you on this case. So you have got pass marks. So yes.
Thank you. Thank you. So moving on to the next session, we have now table viva. Table viva are 2 table viva. It will be of 20 minutes each.
Thank you so
First
much
table
for
viva,
inviting me for
our
actually I'm
guest,
traveling. So I
our
think,
judge is Kauthalkar
in
ma'am.
between this was
She is our own academic head, always ready to help, enthusiastic teacher for the students, approachable. For that, we have the presenter, Dipti. She'll be, Dipti, or yeah. So, Dipti, let's start. Ma'am, Kauthalkar ma'am.
Yes, yes, I am there. So Dipti is there?
Yes, ma'am. Dipti, just hold on.
Okay. So we'll start with the, I think there is pelvis, skull and baby with the placenta. We'll start with the pelvis, Dipti.
Yes.
How do you assess inlet of the pelvis, Dipti?
Inlet of the pelvis should assessed by per vaginal examination. By right hand, we in PV examination by the right hand's index finger and the middle finger, we will try to reach to the sacral promontory. Then we check the curvature of the sacrum by sideways and also above downwards.
My question is related to inlet.
Only we assess inlet by clinical method, that is by Muller-Monroe-Kerr method. That is by left hand we held on the left hand. We held on per abdominal of the patient, and by right hand we do the PV examination, and by left hand we push the head downwards inside the pelvis, try to push, and the thrust feel by the right hand. If it is moving downwards, then we can rule out there is no inlet inadequate.
Okay. How do you measure diagonal conjugate?
For diagonal conjugate, we give the patient lithotomy position. Patient is lying.
I want to know when do you measure also?
Generally, at the term, we do the pelvic assessment, that is to measure the diagonal conjugate.
Why you do the clinical pelvimetry only at term, Dipti? Why not in first and second trimester?
As there is a full growth of the baby and the average size of the baby and the full parameters are developed at that time, so it is necessary to do that term. In the
Proceed. How will you do the? How will you measure diagonal conjugate?
We stand up by the right hand side of the patient, and we do the pervaginal examination. In this, by right hand's index finger and the middle finger, we
what is the patient's position?
We give her a dorsal lithotomy position. Patient lying
position for clinical pelvimetry, Dipti? Every patient, you tell me.
No, we just tell her to lie lie down on in the table.
What is that position called as?
We just said supine position.
Supine
position.
You examine the patient in supine position?
No, we flex her legs, both the legs.
What is that position called as?
Lithotomy position.
What is dorsal position? What is the difference in dorsal position and lithotomy position?
In dorsal position, there is flexion at the legs.
What I mean to say is you examine patient in which position? Now you tell me.
Yes, dorsal position.
Okay. What about bladder?
We should ask her to evacuate the bladder. The rectum should also be empty. It is well and good. Then we assess by right hand's index finger and the middle finger. We try to reach the sacral promontory, and we measure from the lower margin of the pubic symphysis to the sacral promontory, lower border. Sorry, at the eminence of the sacral promontory, and by left hand we we try to locate by left hand which the amount of hand goes inside the, and then we demark that and we remove the hand and we count the length.
How much is normal?
Normally it is 12 centimeters.
12 centimeters. Okay. Now, suppose you are doing a clinical pelvimetry and you are doing a pelvic assessment. How you can suspect about the type of pelvis? How will you diagnose? What is the type of pelvis?
First, in per vaginal examination, we feel the curvature of the pelvis. We feel the sacrum curvature, the side walls, and the interspinous spines are prominent or not, whether the spines are prominent or not.
So
by
how
that
you know what is the type? How will you know what is the type of pelvis? What are the types?
There are 4 types, like gynecoid
So how will
pelvis.
you know? You know the types. Now, how will you know? You are doing per vaginal.
Roughly by the AP and transverse diameter, we assume, and if there is spines are prominent.
What are the features of android pelvis on per vaginal examination?
Android pelvis. It is heart-shaped pelvis. There is
per vaginal examination, you can't feel heart. No? I'm asking you clinically, you are examining how you will know it is android.
We assess, we feel the spinous process. If they are prominent, the walls are convergent, and AP diameter is more in this pelvis. Subpubic angle and narrow sciatic notch.
Narrow sciatic notch and flat sacrum, isn't it?
Flat sacrum.
Flat sacrum is the first clue which you get. Okay. Now coming to the fetal skull, whenever fetal skull, why we need to know about fetal skull?
We know about, we should know about fetal skull, the position, the presentation.
Define presentation.
It is the part of the fetus which lies in the lower pole of the uterus. It is the presentation.
So how presentation we should, we are studying so much about fetal skull. My question is how it is relevant to us as obstetricians.
By that,
where it helps us.
We can assess the descent, the progression of the labor.
Study of the fetal skull. I'm asking you. You must have memorized all the diameters because isn't it obstetric viva? So how it is important, how it helps us when we are managing patient in labor?
By assessing this, we can assess the progression of labor, whether it will progress or not. And
how do you
what position of the
yes. Now there are so many diameters, isn't it? There are so many diameters of the fetal skull. Just enumerate diameters.
And Deepti, you can show them also as well, the pelvis and the skull which you are having it, which madam has asked the questions. You can demonstrate on them also.
Demonstrate. And you tell me all the diameters of fetal skull. Lift up the skull so that we can all see. Yes. What are the important diameters?
There are 2 important diameters. For diameters, we first take the demarcating points like occiput, incipit, and we measure the diameters. There is suboccipito.
The diameters now. Start with the diameters.
Suboccipito brachmatic. Then occipito frontal.
So with your thumb and with your middle finger, you can keep thumb at one point and middle finger at the other, and you can demonstrate.
It is suboccipito brachmatic.
How much? How much it is?
Suboccipito brachmatic, it is 9.5 centimeter.
Next.
Then it is suboccipitofrontal.
Okay.
It is 10 centimeters. Then occipitofrontal. It is 10.5 centimeter.
So what is the significance? In which type or in which situation occipitofrontal will be the diameter of engagement? These are all antero-posterior diameters, isn't it?
Yes, ma'am. These are antero.
So if it is occipitofrontal diameter, it indicates what? Diameter of engagement is occipitofrontal. That means what is there?
Head is
what is happening to fetal head?
It tells about the flexion of the head. It is deflexed head.
It indicates a deflexed head. Okay. What are the causes of deflexed head? At term?
Polyhydramnios. Cord around neck.
Okay. Any position which is associated, which goes hand in hand with the deflexed head? Position of the fetal head? What is malposition?
Malposition is the anything other than
you have a chapter in your textbook, malpresentation, malposition. So what is malposition? What is happening in malposition? It is occipitoposterior. So why occipitoposterior is associated with deflexed head?
Engaging
why occipitoposterior position, the deflex head is more common with occipitoposterior as compared to occipitoanterior position. What is the reason? That is my question.
Because the engaging diameter here is occipitofrontal.
So why it is occipitofrontal? Why not suboccipitobregmatic? How much time, Amrita? How much more time? Amrita, how much time we have?
Ma'am, 2 more minutes we have.
2 minutes. So coming to the third, where there is a fetus with the placenta, isn't it, Dipti? So how do you examine the placenta after the delivery?
We examine the placenta by both the seeing both the surfaces of the placenta. There is
how do you suspect succenturate lobe? What will give you a hint that there is a succenturate lobe?
If after removing of placenta also, is there is excessive bleeding, it might give suspicion of, and there is
examination of the placenta. I'm asking you, if you are examining the placenta, there is important clue which you can have.
Cotyledons
tell you that there is a possibility of having a succenturate lobe when you are examining the placenta. Do you examine the placenta after delivery, after each delivery? Yes. How are the vessels running?
Towards the umbilical cord.
Vessels keep on getting thinner and thinner towards the periphery. But suppose they are not getting thinned out and they are equally thick at one place, that tells you that there is a possibility of having a succenturate lobe. Okay.
Ma'am, actually the time is over, so can we conclude?
Yes, we can. So Dipti, what was the topic given to you for the obstetric viva? What was told by organizers to you?
Dipti,
what was told to you? So suppose you are preparing for obstetric viva, anything related to labor. It's not that pelvis you will be asked about the UG level questions as diameters of inlet, mid plane and the outlet. How clinically you assess as a postgraduate, that will be the most important. That is one thing what I feel is. And whatever you are learning, suppose you are learning about fetal skull, always think how it is going to help me. It's not that fetal skull is only theoretical and then you enter the labor room and you do whatever. You need to apply whatever your knowledge you gain when you learn about the pelvis, when you learn about the skull. So how to apply? Think that way as a postgraduate student. Okay, well done. Thank you.
Thank you.
Thank you, ma'am. Thank you so much for guiding the Viva from the very basic things to very minute details of such a basic obstetrics. Thank you so much. Thank you, Deepti. So let's move on
You are
to our
most
next slide. Deepti, stay back with us. We'll have a next slide for you. For next slide, we have the next eminent faculty with us, Dr. Neema Acharya, ma'am. Welcome, ma'am. She is the professor and HOD at Datta Mege Vardha Savangi. Thank you, ma'am. Thank you for accepting the invitation at the NNTAR.
Good morning.
Over to you, ma'am.
Yeah.
Deepti? Yeah, be ready.
Who's the candidate? Deepti.
Deepti, ma'am. Deepti Kadam.
Good afternoon.
Okay. Okay. So very good afternoon to all of you. And as postgraduates, you know, not much is going to be asked to you on endoscopy as such. But yes, basic endoscopic things, you know, equipments we all should be aware of. So Deepti, what is the slide showing right now? Can you describe the instrument?
The first instrument in the slide is the Very's needle.
Okay.
Very's needle is used in laparoscopy for creating the pneumoperitoneum. It is made up of stainless steel. It has outer needle and inner stellate.
Okay. Now, what is the purpose of Very's needle? Why it was devised?
It was first devised to create a pneumothorax. It is used in pneumothorax first, and then it invented and getting used in laparoscopy to create the pneumoperitoneum.
Okay. So, what is the advantage of putting a Very's needle and creating a pneumoperitoneum before laparoscopy?
By creating pneumoperitoneum, we ensure that we didn't get injured to the bowel and the inner visceral structures and the field of.
Okay. So, how exactly are you going to put the Very's needle? Have you seen any time?
Yes, ma'am.
How it is held? How you put it inside?
Yes, we hold like in pencil fashion.
Okay.
We give
Like
incision.
Not pencil, dart.
By supraumbilical incision, we put 45 at the angle of 45 degree. We insert the Very's needle. It has a blunt end stellate, and the outer needle is of 16 gauge. So it will help to penetrate the skin and the subcute, and the stellate is given that so that inner viscera should not get injured. Then we insert it. Then we felt the thrust of rectus sheet, and we ensure that we gone inside.
How do you confirm that it is inside the peritoneal cavity?
By adding a saline drop in this. If the saline drop sinks in below, and second, by we inject the saline and we aspirate then back. If it is not aspirated, it means it is inside the cavity.
Okay. So now, once you are sure that you have, you are inside the peritoneal cavity, you are going to connect it to the this thing, tube, pneumoinsufflator, right? So then what happens? How do you have you ever seen the pneumoinsufflator and how you read the fire? You know, the readings on the pneumoinsufflator, the actual pressure, set pressure, and all that. Are you aware of that?
I saw, ma'am, 12 mm of Hg pressure, sorry, centimeter of waters. pressure is generally.
When you actually do actually go ahead with the procedure, when you put the primary cannula and all, trocar and cannula, and later on when you put endoscope, laparoscope, then what is the pressure, and what pressure you can have with various needle to, you have a little more elevation of abdominal wall so that you don't injure while putting the primary this thing cannula.
12 to 15 centimeter of water.
क्या रहता है उसमें स्केल क्या रहती है? So please go and see, what happens whenever you are, for all aspiring endoscopic surgeons also, make sure that, all young budding gynecologists are also here, I think. So I would request all of you, doing those online courses for 10 days, 5 days, 3 days. Okay, you can do that for your certificate purpose. But before you go for any skill training in laparoscopy, see to it that you have understood the trolley very well, right? Right from monitor, camera, to your light source, to everything. All the equipment has to be understood very well. That means the interpretation of all the readings which come on the scales, different equipments you should be aware of. Otherwise, they are telling you a lot of information, even your energy sources for that matter, right? Now, which is this instrument which is now projected?
It is trocar and cannula, ma'am. It is made up of stainless steel. It has various sizes like 5 mm, 7 mm, 10 mm.
Okay. So what are the normal usual sites of putting the primary cannula or through which the laparoscope is put in?
Primary, supraumbilical.
How about the umbilicus? Supraumbilical matlab? Have you seen?
Yes.
Say if you're doing a diagnostic laparoscopy, the sonography is not showing any pathology, and you are doing a diagnostic laparoscopy, say for tubal block or a simple subfertility patient, right? And another patient who has a big fibroid, you're doing TLH. Is there any difference in putting the primary port, or it is going to be same?
If it is big fibroid, we will go for supraumbilical, and if we have to see only the adhesions and this, we give incision below the umbilicus.
Nima ma'am,
yeah,
we have last 2 minutes. Could you please summarize from a resident point of view at PG level, what all things they should know about laparoscopy from exam point of view?
So basically for laparoscopy, number one is what exactly is laparoscopy? What are the gynecological indications to do laparoscopy, right? And then how you preoperatively assess the patient before you post her for laparoscopy, right? And then the pre-anesthesia also workup is very, very important, because you are going to post the patient and you're going to put a lot of gas under pressure. So pre-anesthetic evaluation is very important. And second thing is the planning of, the position, how position kaisi deni hai. Then how are you going to put the ports, the port placements. Then, as I told you, the most important thing about any higher ended learning which you are going to do, whether it is assisted reproductive techniques or endoscopy or any other branch for that matter, learn the equipment basics very well. If you have not understood anything about energy sources, don't touch that harmonic scalpel. Don't touch that energy source at all. अगर आपको मालूम ही नहीं है monopolar क्या है, bipolar क्या है, don't touch it. If you've not understood it. Port placement is very important. You should know the anatomy of anterior abdominal wall very well, very well. है ना? Anatomy pelvic तो है ही, but ports में अगर आपको diagnostic laparoscopy भी डालना है with some ancillary port, and if you don't know the anatomy, it's going to create havoc for you. So understanding the instruments, understanding the equipment, understanding the ergonomics, and understanding the energy sources is very, very important. And surgical anatomy तो वो तो anyways OBGY में आना ही है आपको for anything. But for endoscopy, if you specifically asked me, these things are very important. So just don't learn TOCAR and cannula. अगर आप वेरीज पढ़ रहे हैं तो वेरीज जब वो ट्यूबिंग को कनेक्ट होगी तो उधर क्या क्या फाइंडिंग्स आएंगे, है ना, वो न्यूमो इंसफलेटर पे, और उसके इंटरप्रिटेशंस क्या रहेंगे, लाइक सेट प्रेशर इतना है, एक्चुअल प्रेशर इतना है, और गैस ही नहीं जा रही है. So what is the interpretation? There are 4 or 5 possibilities different. So in a given short span of time, we cannot discuss that. But this much, because you are going to do diagnostic laparoscopy at least, isn't it? So you all should be knowing this. And complications can occur in any patient, right? And so if you're anticipating previous to cesarean section patient hai, anticipating adhesions, endometriosis patient, initial port आपको Palmer's point पे डालना है. So there are many things, you know, which you all should be knowing. So Palmer's point भी आपको पता होना चाहिए, वहां से क्यों जाते हैं, RT क्यों डालनी है आपको, right? And equipments में there is no end, you know, कि आपको क्या पूछ सकते हैं, monopolar current, bipolar current, what is ligashore, है ना? So I think read everything in detail, and basic equipment सबको आना चाहिए, primary, ancillary, cannulas, all those things, trocar cannulas. I thank Prachi ma'am for giving me this opportunity, and I'm always there for you, Prachi. Anytime you can call me. Thank you so much.
Heartfelt thanks to ma'am. Now
Thank you
we
so
have,
much, ma'am.
shifting to our next table viva. Tuhina, you are, yeah. For the next table viva, we have our next judge. We have Dr. Seema Parvekar ma'am with us. She is medical superintendent at Daga Hospital, Nagpur. She has many awards and achievements in her bag. She has very nice publications, AHC Lancet paper in Intervention Journal, and heat stable carbetocin versus oxytocin to prevent hemorrhage after vaginal birth. She has special interest in NDVH, vaginal surgeries, and obstetric emergencies and family planning. Over to you, ma'am. Ma'am, I think so you need to your voice is not heard, ma'am. Ma'am, unmute. It's not written. Tuhina, wait for a moment. Ma'am, some audio issue from your side. Yes, ma'am, we can see you. Yeah. Ma'am, we are giving you a call. आपको रेड कलर हाँ आता झाले अनम्यूट एक मिनिट आवाज तो नहीं आ रहा है नहीं मैम एकदा तुम्ही लॉग आउट करून पुन्हा लॉग इन आपके लैपटॉप में से पूछो उनको वॉल्यूम का मैक्सिमम प्रेस्ड है हम लॅपटॉपचा व्हॉल्यूम पूर्ण मॅक्सिमम आहे मग एकदा लॉग आउट करून पुन्हा लॉग इन करून बघा हाँ मैम नो इश्यूज नो इश्यूज उनके पास ईयरफोन होंगे तो उससे पूछो ना ईयरफोन next person is ready. मला आवाज येतोय आता.
एक और इसे लॉगिन किया है.
और नाही मॅम फोन मधूनच येतोय.
इसमें
आवाज
सब
है?
नहीं.
मॅम इयरफोन्स.
अच्छा ठीक है. तुहिना, can you hear ma'am?
Yes. No, ma'am.
Okay. One second. From here, please increase the volume.
स्पीकर में थोड़ी.
Tuhina, can you hear us?
Ma'am, it's resonating. I can't hear it clearly.
Okay. Seema ma'am.
आपको सुनाई दे रहा है?
ईयरफोन. अगर ईयरफोन होगा तो एक बार लैपटॉप में लगा के वो आप देखो, शायद फिर आपका वॉल्यूम हमें सुनाई दे. हाँ मैम, आपका अभी भी सुनाई नहीं आ रहा. ईयरफोन है क्या आपके पास? उसमें लगा लीजिए. हाँ जी मैम, कोई बात नहीं. हाँ मैम, कोई बात नहीं. We'll move on with the next session. Okay. Yeah, we'll just see, Trina, 2-3 more minutes. Otherwise, we'll shift to the next session and we'll get back to ma'am again for you.
Okay, ma'am.
Seema ma'am, if you have some technical issue, then we can shift to next case and we'll get back to you after the next case. In the meanwhile, you can sort out your technical part. Okay, ma'am? Is that fine? You can show the thumbs up, ma'am, if not audible. Is it fine, ma'am? Okay, ma'am. See you then after this case. For the next case, we have a case on carcinoma cervix. Rajat. Tuhina, we'll see you in a while. Rajat is our case presenter. We have our faculty, Dr. Bangal sir, Dr. Rujita Fuke ma'am, and Dr. Monica Akre ma'am. Welcome, Bangal sir.
Dr. Bangal sir, he is a professor and head of department at Pravra Institute of Medical Science. He has a huge teaching experience of 31 years. He has lots of research publications to his credit. His special areas of interest are high-risk pregnancy, obstetric emergencies, community obstetrics, and healthcare quality. Welcome, sir. Welcome, Rujita ma'am. She is Associate Professor, Department of Obstetrics and Gynecology at GMC Nagpur. She's been trained in colposcopy, fetal medicine. She is a fellow of Indian College of Obstetrics and Gynecology. She has many poster presentations to her credit. She has many national and international publications. Welcome, ma'am. Welcome, Dr. Monica Akre, ma'am. She has done her MBBS and MD from prestigious institutes. She is assistant professor at IGGMCH Nagpur. Over to you, Dr. Rajat. You can start your presentation. Rajat. I think so. Rajat is also having. Mangal sir, we'll just wait for 5 more minutes. Even Rajat is getting some technical thing. Yes.
क्या है स्नैप है उसको बोलो कि सॉर्ट आउट करेगा सबका नोट समझ आ रहा है या अपनी एक पॉइंट अरे कौन है इतने बनाना
मैम यहीं से लॉग देना Mangal sir, can you hear us? Sir, could you please unmute yourself? Sir, your mic is still showing muted. That red. Okay, Rajat, can you hear us?
I'm just trying to connect my PC again. I'm facing some technical
We can
issues.
hear you, Rajat. Could you be a little louder?
I'm not able to start my video. Just a second.
Wait.
Just a second. I'm just trying to start my video.
हम त्यांना अनम्यूट करायला सांगा ना.
I'm not. I won't. Hello.
सगळ्यांना अनम्यूट करून टाका त्यांना सांगायचं आपलं आपलं म्यूट करून बघू हे असं आपण काही करायची गरज नाही
Rajat.
Sir.
Yes.
Okay.
Good afternoon.
Rajat, please, yeah. Rajat, I guess without your PPT, you can read out at least so that we can start with the discussion. Rajat, please respond.
Okay, fine. I'll do that. Am I audible? Hello, am I audible, ma'am?
Yes, you're audible. We will do a thing. If you're finding it difficulty in uploading the case, kindly just read out so that our guests, our judges can ask you questions. Okay, Rajat?
Okay. Yeah, absolutely fine. Yeah, I'm starting my case. Good afternoon, everyone. Today I'm presenting a case of.
Just hold on, Rajat. Just stop sharing that screen which already you have opened up.
Okay.
Is it fine, Bangal sir, Bonika ma'am? We can start the case with the Rujita ma'am. If Rajat speaks and talks about his case, is it fine with you, judges? Okay. Monica madam.
त्या ब्रदरला माहिती कसं यूज करायचं ट्रेनिंग झालं ते त्याने
Rujita ma'am,
आम्हाला सांगाल ते कसं यूज करायचं.
we can start the case. Monica ma'am. Rajat.
Yes, ma'am.
He's presenting.
Rajat, you can start, I
Yes.
guess.
Okay, fine. Sure, no? Should I start, right, ma'am?
Yeah, you can start.
Okay.
1 second, let me ask the judges. Bangal sir, Rujita ma'am, Monica ma'am, should we begin? When Rajat responded, we could hear. Rutuja ma'am and Monica ma'am, Bangal sir will take some time due to technical thing. Can we start? Rajat, are you ready? Rajat, you can start. You can start presenting the case, Rajat. It's a network. Network.
Am I audible, ma'am? Ma'am, am I audible?
Audible, please. Monica ma'am. It's a technical problem with her, ma'am.
अरे सुना इधर आना फटाफट 5 मिनट। अभी क्या करूँ इसमें? एक मिनट चालू करना।
तेरे को तेरा मेल आईडी ओपन करना पड़ेगा।
नहीं तेरा भी चलता, कोई प्रॉब्लम नहीं, विंडो ही तो चाहिए अपने को।
तेरा नेट कनेक्ट।
नेट मेरा चालू, हॉटस्पॉट चालू है मेरा।
आरजे वाला?
हाँ आरजे 8 बार छोटा है।
8 बार
छोटा है।
1 2 3 4 5 6 7 8।
हाँ मेरा व्हाट्सएप ऐप चालू कर दे इसमें, फिर मैं करूँ।
व्हाट्सएप पे चालू करते वो नहीं
वो
कर
मेरे चालू
हो गया अभी?
हाँ
अभी कुछ नहीं है?
Sanjayta, could you please unmute Monica madam, Monica Kare madam?
Okay, ma'am. 1 second. I said check.
And please unmute Bangal sir also. By Dr. Savita Sumalwar ma'am. उनके नाम से होंगे, प्लीज उन्हें अनम्यूट करो। अब वो भी हो गई मैडम।
Which case we are taking now?
Shall we start?
Which case we are taking?
CA survey, it will be by
Okay, yeah.
Rajat.
Please go ahead.
Rajat, please share the screen. Rajat. Do not call Rajat again. Yeah. I'm त्याच फोन वरून he is sharing the screen वगैरे सब. Actually, can't help it. Sorry, sir, just 5 more minutes. We will just see whether our candidate is able to log in or not. We'll update you very soon.
Can we project from our side, means your side, his case?
Sanjayta, could you please allow Shraddha? Rajat will be presenting through her app.
Okay.
Dr. Shraddha करके Shraddha Thakre. Yeah, Rajat, we have unlocked Shraddha. Could you please now say hi, hello, whatever?
Yes, ma'am.
Now you heard. Now kindly update it now. Share
okay,
it.
Yes, ma'am. Just a second. Ma'am, I'm not able to share my screen since the host has disabled the participant to screen share.
Share screen you need to.
Yeah.
Sanjayta, unmute also. Sanjayta, are you there?
Yes, ma'am.
Sanjayta?
Yes, ma'am.
Sanjayta?
Yes, ma'am.
Yeah, did you make Shraddha Thakre as a co-host?
मैम मैं बना रही हूँ 2 मिनट कोई इशू आ रहा है टेक्निकल आई विल चेक
बना रही इशू हो रहा है
श्रद्धा ठाकरे को co-host बनाने में इशू आ रहा है What is the problem? Unmute everybody now. Sanjayta, unmute everybody.
मैम अनम्यूट ही है
स्क्रीन करने के लिए co-host होना है वो नहीं कर पा रहे
Rajat, please unmute yourself.
Okay.
Yes.
Okay.
You can start your case now. There is no need of, it is not must that there should be PowerPoint presentation.
True,
You can
sir.
just speak out.
Sorry, sir, for the
Okay.
delay.
Okay, ma'am. Okay,
Rajat,
sir.
just start it off. Even
There's
if you are
no
not
need of
able to
PPT.
upload it, please read it out.
Okay. Sorry for the delay, everyone. Good afternoon, everyone. Myself, Dr. Rajat Agarwal, a junior resident third year from IGMC Nagpur. Today, I'm presenting a case of carcinoma. A 47-year-old lady, Hindu by religion, residing at Gaddigudam, Nagpur. She is illiterate and is a homemaker, and her husband is a laborer by profession. She belongs to lower class by according to the modified Kuppaswamy scale. Came to the gynecomist at IGMC with chief complaint of bleeding per vagina 1 month. Patient was apparently all right 4 months back when she started experiencing spotting PV after having intercourse, for which she did not see any medical advice. Since 1 month, she started with a bleeding vagina, stage of 4 to 5. Reply. Audible.
Yeah, Rajat, you are audible.
Okay, I'll start with my case. A 46-year-old lady, Hindu by religion, residing at Gaddigudam, Nagpur. She is illiterate, is a homemaker, and her husband is a laborer by profession. She belongs to lower class according to the modified Kuppaswamy scale. she came to the gynecopedy at IGMC with a chief complaint of bleeding fever since 1 month. Experiencing intercourse with her husband, following which she did not seek any medical advice for the same. Since 1 month, she started bleeding with heavy with shortage of 4 to 5 pads associated with patch of clots, which was not associated with pain. With complaint of generalized weakness after 15 days. There was no complaint of any false swelling bite discharge, no complaint of pain in lower abdomen, loin, legs, and back, no complaint of bowel or bladder symptoms, no complaint of weight loss or fever. She got married at the age of 20. She is by obstetric formula para 3 life 3 all by vaginal delivery, last childbirth and TL done 20 years back. Her last menstrual period was at 20th January, which is ongoing till date with soakage of 5 pads per day. Her last to last menstrual period was on 16th December, which lasted for 4 days with soakage of 3 pads per day. She had regular menses lasting for 3 to 4 days with 25 to 30 days duration with average flow, soakage of 2 pads per day, not associated with dysmenorrhea. She had a bilateral tubal ligation done, and there is no history of any steroidal contraception used. The past history and she had no significant past history and past surgical history. Her family history is also not significant. Her personal history, she consumes mixed diet, sleep, bowel, bladder habits are normal. There are no addiction or drug allergies. On general examination, patient was conscious, cooperative, well-oriented to time and person. She was averagely with a height of 162 centimeter and weight of 151 kgs. On general examination, her general condition was fair, afebrile. Pulse was 86 beats per minute, regular good volume. Blood pressure was 120 by 80 millimeters of mercury. Respiratory rate 18 per with severe pallor present on lower palpable contact. There was no lower limb edema, no palpable lymphadenopathy, clubbing, icterus, sinus edema. There was no thyroid gland visible thyroid enlargement with bilateral breast soft and no palpable breast lump. Her CVS and respiratory system examination were normal. Per abdominal examination, her abdomen was soft. There was no presence of guarding tenderness and on per speculum examination, a polypoid mass of 5 by 5 centimeter arising from anterior cervical lip, which was painless, friable, and which was bleeds on touch, and the vagina appeared to be healthy. On per vaginal examination, a mass of around 5 by 5 centimeter present, which was arising from the anterior cervical lip, which was bleeding on touch. Non-tender bilateral furnaces were free. Uterus was anteverted, normal in size, and which was mobile, and bilateral adnexa was clear. On per rectal examination, after taking verbal consent, the rectal mucosa was free, the parametrium was free, and there was no nodularity felt. My diagnosis for this case is provisional diagnosis is 47-year-old para 3 life 3 with carcinoma cervix, clinical stage 1B3 under evaluation. Thank you.
Hello, Rajat.
Yes, good afternoon, sir.
Yeah. What is your differential diagnosis for this case?
So differential diagnosis could be mucosal polyp, mucosal cervical, which could be in spite of carcinoma cervix, and could be a cervical polypoidal fibroid, degenerated cervical polypoidal fibroid.
Any other thing that comes to your mind?
Sir, so that would be...
Yeah. Why it cannot be chronic inversion?
Sir, because her uterine fundus was palpable and on PV per vaginal examination. That is the reason why it could not be chronic uterine inversion.
Okay. What is the type of this growth in your case?
Sir, it was polypoidal. Sir, it was polypoidal exophytic growth which was present on the anterior lip of the cervix.
Okay. And staging, you say 1B3.
1B3, yes, sir.
Why 3?
Sir, because it is the volume of the lesion is greater than 4 centimeter, which comes under bulky 1B3.
Okay. The fornices are not involved.
Yes, sir. The bilateral fornices were not involved. Parametrum was not involved. So that is the reason that stage 3 goes. Bilateral fornices was also not involved. Though that is the reason why the stage 2 can also be get eliminated. And it was greater than 4 centimeters. So it came out to be. So I classified it as IB3, 1B3.
Okay. So how do you confirm your diagnosis?
Sir, we can confirm this diagnosis by usually carcinoma cervix is diagnosed clinically, staging is done clinically, but confirmation of the diagnosis can be done by histopathologist, by taking a sample from the punch biopsy.
What histopathology report you expect?
Sir, looking at the lesion, it could be, sir, since it is arising from the anterior lip and it is exophytic, so probably the lesion is coming from the ectocervix, and from the ectocervix, the most common histopathological report could be squamous cell carcinoma, but it's a type I could not comment on the type of which type of squamous cell carcinoma is present, sir.
What precautions you like to take while taking punch biopsy?
Sir, while taking punch biopsy, first I would like to. I will not do a pervaginal or PV examination before taking the biopsy, and I should have I should be well prepared for the amount of bleeding which is expected to happen after I take the biopsy. So I would be prepared with drugs which would help me in preventing the amount of bleeding after taking biopsy. So I would give her and prophylactically I can give her tranexamic acid before I take the biopsy, and I would take it from the periphery of the lesion and not from the center of the lesion, because center of the lesion could be necrosed and periphery would have a better quality of tissue, which would help the pathologist to diagnose it in a better way.
What all measures can be taken if there is a brisk bleeding from the biopsy site?
Sir, there are 3 things which we can do. We can do a vaginal packing soaked in some hemostatic solution. We can use a Moncel paste. There has been traditional use of Moncel paste which has been done, and IV tranexamic acid which could be also used.
You will remove this pack after how much time?
Sir, I will observe for around minimum for a minimum of 24 hours and see whether the pack is soaked or not. If the pack is soaked or minimally soaked, I could remove it after 24 hours. And if it is soaked, then I would and I would keep it for more around 24 hours and reassess whether the pad is soaked or not.
24 hours is a little more time you are saying. 24 hours are not required. Just it's a pressure packing, no? So maybe a few hours, 4 to 6 hours are enough. 24 hours, there is an added risk of infection, unnecessary. Okay. Whether you like to give any antibiotics to this patient and which antibiotics you will choose. Any case of invasive cancer, which antibiotics you will choose?
Sir, I would like to add metronidazole, and for gram-negative organism, I would like to add some amikacin or gentamicin for the gram-negative organism. And for anaerobes, I would like to add metronidazole.
And gram-positive?
For gram-positive, I would like to add any third-generation cephalosporin.
Okay. Within how many days we are likely to get the report? HPR.
In around 5 to 7 days, we get the report in our institute.
Okay. So it confirms that it's a squamous cell carcinoma. Okay. Stage 1B, as you said. What additional investigations you would like to do? One after histopathological confirmation.
Sir, I would like to.
Yeah.
Sir, I would like to check her lymph node status and also her urinary tract, the whole respiratory system status by doing a CT scan, sir, which would give me a idea about how many whether the nodes are involved or not, and the nodes, if the nodal involvement is positive and it is greater than 1 centimeter positivity in CT scan, I would like to go for PET scan, sir, to make it a confirmed diagnosis. And if the report in the CT scan comes as a suspicion that there is a suspicion of positive lymphadenopathy, I would like to go for CT guided FNAC.
You will prefer CT or MRI?
So for nodal involvement, I would like to.
Rajat? Yeah.
Hello?
So sorry,
yeah.
For primary assessment of the tumor, to know whether the extent of the tumor, we would like to do MRI, but for the nodal involvement, CT scan is the best. And if there is greater than 1 centimeter of there is if the nodal involvement is in 1 centimeter, the guidelines says that it is, we should go ideally go for PET scan.
For stage 1B, what is the possibility of nodal involvement?
Sir, for stage 1B, the possibility of getting the nodes involved is, I don't know the exact percentage, but there could be involvement of the parametrium and the paracervical lymph node at least.
Nodal
We
involvement
welcome
depends.
Anuja ma'am also, our HOD professor.
This nodal involvement depends on what all factors?
Sir, whether if the microscopic invasion is greater than 3 millimeter in depth and 5 millimeter in paralleling, there is a possibility of lymphovascular invasion if the micro invasion is greater than 3 millimeters, sir. And that could alarm me that whether the lymph nodes there is a high possibility of getting the lymph node involved, sir.
Why we are interested in knowing the lymph node involvement?
Sir, because lymph node, because whether if the lymph node, we want to know whether the spread has already occurred via lymphatic route or not.
Why?
And that could also
Rajat,
help. So that would help. Yes, ma'am.
Rajat, since we are talking about lymph node involvement, what is your thought about a sentinel node in patients with CA cervix?
Yes, ma'am. That is a very good diagnostic, good interop diagnostic procedure where we put a methylene blue interop, and whether if it gets changed, that means that the lymph nodes are involved, and we could do lymphadenectomy interop. So we would know that the primary lymph node of the tumor which drains the tumor is that or not.
Which are the first group of lymph nodes that get involved in cancer cervix?
The first group is usually, sir, parametral and paracervical lymph node, which goes to common external iliac, internal iliac, common iliac, and then para-aortic lymph node.
Okay. Anuja, you want to ask anything?
Hello.
Anuja? Yeah.
Yes, ma'am.
What other investigations? Any tumor marker you know for cancer cervix?
So there has been no tumor marker for CA cervix. So I don't know any such tumor marker for CA cervix. I just note whether we can go for HPV testing, because without HPV DNA TCR we can go for that, sir. Because that is a most common 99%, 19.5%. It is always associated with HPV.
So what would be the first modality of treatment for this case?
So first modality of the treatment would be concurrent chemoradiation. Since this is a bulky tumor, we would like to go for chemotherapy, which will act concurrent chemoradiation. Chemotherapy will act as a radiosensitizer for the radiotherapy, and it will enhance the effect of radiation therapy, which will be used for the treatment. Usually a single agent is used in the chemotherapy, which is cisplatin. But if the patient has any neuropathy or anything, any renal disease, chronic renal disease, we could go for gemcitabine, or we can go for gemcitabine and one more platinum.
Okay.
There was one more. We can go for gemcitabine. Then we would like to go for radiation therapy. Radiation therapy includes two things. That is, first we would the concept behind radiation therapy is that we first reduce the tumor load by giving external EBRT, that is external beam radiotherapy. And with that we could start with brachytherapy, that is giving the radiation at the local level. Usually 5 fractions of radiotherapy are given per week for 5 weeks. That is total of 25 fractions.
What is the cancericidal dose of radiotherapy for CA cervix?
Sorry, ma'am, I'm not able. Can you just repeat the question, ma'am?
What is the cancericidal dose of radiotherapy for CA cervix?
Cancericidal radiotherapy. Okay, ma'am. Total of 45 to 60 grays is given by external beam radiotherapy, and around 15 to 30 grays are given by brachytherapy.
Okay. Suppose your patient would have been a young one or a young woman, what would have been your plan of management?
Ma'am, for patients who are young, it depends on the stage whether we want to preserve the fertility status of the patient or not. First, we would like to go for stage 1A1. If the stage is 1A1, we would like to go for conization to preserve the fertility of the patient, ma'am.
Your patient is stage 1B, no?
No, ma'am. No, my stage, ma'am. My patient is stage 1B, 1B3.
2.
1B3, ma'am.
1B3. So how you would have managed if your patient would have been young?
Ma'am, my patient, if I would like to go for a neoadjuvant chemotherapy, which will include dual duct therapy, cisplatin and paclitaxel, followed by which we would go for fertility preserving surgery. Fertility preserving surgery includes trachelectomy with pelvic lymphdectomy. That is a radical trachelectomy.
What are the 5 important steps of trachelectomy? You mean to say trachelectomy would help you in your patient who has got such a big growth?
Actually, ma'am,
trachelectomy is not indicated in patients with a bigger growth. My question is, if she would have been young and she's where the vagina is not involved, what is the mode of surgery that you would like to go in for? Any radical hysterectomy that you know of?
Yes, ma'am, we could go for radical hysterectomy, which includes modified radical hysterectomy, which also known as Wertheim's hysterectomy. But that would not, one second, just a second, ma'am. That would not save the fertility or. Ma'am, I want to ask whether we want to preserve the fertility or not. If we want, if
So
you
she's
don't
a
want to
young
preserve
woman. What is the
Yes,
major drawback after use of radiotherapy?
ma'am, the ovarian reserve usually gets lessened, and also there is this problem in having
Psychiatrization of
common
vagina,
complication.
which is so very important for quality of life.
Rajat, can we preserve ovaries during radical hysterectomy?
Sorry, ma'am, can we what?
Can we preserve the ovaries during radical hysterectomy?
Yes, ma'am. Yes, ma'am. We can very well preserve the ovaries during radical hysterectomy. We can keep it in the paracolic gutter, and also if we want to preserve the ovary before radiation, if we can keep it in the paracolic gutter so that it doesn't come in the range of the extra EBRT, that is L4 and LS1 space, intervertebral space, and the ovarian reserve could be saved for preserving the fertility.
What are the advantages of surgery over radiotherapy?
Ma'am, over radiotherapy, the treatment, the recurrence rate, the fertility could be preserved. That is, ovarian reserve won't be affected. There won't be any vaginal cicatrization, as mentioned by ma'am, and also her quality of her quality of life would be better, because once the surgical treatment, after getting surgical treatment, the quality of life is way better than after having a radiotherapy. This after this the patient could get saved from the side effects of the radiotherapy.
What is your take, Rajat, if the patient has got a bigger mass, and what is the mode of management in these patients? Can you give radiotherapy and then do a radical hysterectomy, and within how much time we can do that?
Ma'am, if the tumor size is greater than 2 centimeters, which is in my case, we could go for neoadjuvant chemotherapy, which would reduce the tumor size, and also we could start with concurrent radiotherapy. In which we could start with external beam radiotherapy first, which would reduce the tumor load, and then we can go for brachytherapy. And there has been two new modalities in the radiotherapy treatment, which is intensity modulated radiotherapy, which is a CT guided radiotherapy, in which we detect whether in which part of the tissue is more affected, so that we could target that tissue and hit it with the radiotherapy. And does not kill the normal cells which are not in. That is the two basic benefits of the new modality of the radiotherapy.
Tell me something about long-term follow-up of cases treated for cancer cervix. How will you advise?
Sir, if we give a if we have done a surgical treatment of the cancer CA cervix, we could go for a 3 monthly follow-up for 2 years, followed by 6 monthly follow-up for 3 years, and by after that annually for lifelong, and usually it is for 20 years. And if we have given treatment radiotherapy or chemotherapy, we could go for monthly for 3 months, and after that same as surgical treatment, sir. Same as surgical follow-up, which I have mentioned.
During follow-up, what you will observe, ask, or examine?
During follow-up, I would like to do from head to toe examination, which will include.
You like to speak to her. You like to ask her something. How will you communicate with her?
Sir, I
What
would
will you
like to ask
communicate?
her. Sir,
What
I would
will
like
you
to ask her whether.
communicate? Communication.
Sir, I would like to ask her for any new symptom which she has, whether she has anything, any bleeding from the vagina, or any complaint which is a postcoital bleed or intermenstrual bleed. I would also like to ask her for weight loss. I would also any all the general symptoms which is usually seen in the CA cervix, and we would also like to go for. But I would like to do a pap smear, repeat pap smear from the vault. I would like to go for like to see for nodal involvement, and if the whether the metastasis has occurred by doing a PET scan, which is the best modality to assess whether the disease have progressed or not, or disease have gone to a stage of metastasis or not, and also if whether the patient has any symptom of hematuria or bleeding per rectum, which would give me a hint of whether the disease have spread to the bladder or the rectum. And, that's it, sir.
What is the role of cystoscopy in cancer cervix?
Sir, cystoscopy gives us a direct visualization of the bladder epithelium, and we could also it is diagnostic as well as it is usually diagnostic in nature, because when we go in the bladder, we could take a we need it. We need a histopathological diagnosis to prove recurrence of the disease. And the same is the role of sigmoidoscope, flexible sigmoidoscopy in it.
On
What is your
cystoscopy, is it important? What's the hello, Rajat? On
Yes, ma'am.
cystoscopy, if you are finding bullous edema, what does that signify?
So that, ma'am, bullous edema does not signify anything that it is non-significant in case of CA cervix. It doesn't signify that the tumor has locally advanced into the bladder.
Involvement of bladder suggests what stage?
Sir, involvement of bladder will suggest for stage 4A.
Stage 4A.
Yes, sir.
What are the indications for urinary diversion in cancer cervix?
Sir, if the patient has come to us with the history of recurrence, we could do type 4 radical hysterectomy, which type 5 radical hysterectomy, which involves the proximal removal of the bladder and the ureter if the base of the bladder is involved and it is invaded.
In how many percentage of patients post radiation you get VVF, and what is the cause of VVF?
Actually, I have no idea about the incidence of the VVF, cause of VVF.
End arthritis. After radiation, the fistulas are because of end arthritis.
Okay, thank you, ma'am.
How this case could have been prevented?
Sir, this could have been prevented at a very earlier stage if this patient could have done primary, could have underwent primary screening of CA cervix, which takes around because CA cervix is a preventable cancer, which takes around 10 to 30 years to develop into a cancerous state. If she would have underwent some screening test, which is pap smear or HPV testing, she could have been prevented from landing up into 1B3.
What do you think the role of HPV vaccine in prevention of this cancer? HPV vaccine.
Sir, the role of HPV vaccine is very important. It is of very important, and it should be given to every woman who is between the age of 9 to 26 years. And recently there has been change from 9 to 26 to 9 to 45 years. Previously it was for before initiating sexual activity, but recent guidelines says that it should be given irrespective of the sexual activity also. If it is given before the at an early age, at an earlier age, it is more effective as compared when given after at an later stage, that is in the active reproductive life. There are three types of HPV vaccines, which is Cervarix, which is a bivalent vaccine, includes 16 and 18.
Tell us something about nonavalent.
Nonavalent, ma'am, nonavalent vaccine is a Gardasil 9 vaccine, which includes prevention against 9 types of HPV types, which is 6, 11, 16, 18, 31, 33, 45, 52, 58. Which include which are the most common cause and which are the most commonly involved when in the pathogenesis of the CA cervix.
Okay,
But this
Rajat,
is
you are
not
answering quite well. So just one thing, tell us what are the 5 important steps of trachelectomy, radical trachelectomy? 5 important steps.
Ma'am, I don't know the type 5 important step, but I could tell I could give you an overview of what is done in the radical trachelectomy. The uterus is being preserved. There is at least a minimum of 1 centimeter margin which is kept tumor free. After removing the cervix, we also do parametral removal with pelvic lymphadenectomy, and after that we just like we communicate the rest of the uterus with the vagina, so that she could have her
fertility preserved.
Fertility, yes, ma'am.
So very well presented, and
now, ma'am, there has been
yes,
okay,
please
go ahead, ma'am. Can I add one more point?
Yes.
Now there has been a concept of simple. That previously it was just conization and radical trachelectomy in the fertility preserving surgeries, but there has been new concept that of simple trachelectomy, which has been introduced because when the tumor size is from the 1 centimeter to 2 centimeter, the risk of recurrence or risk of parameter involvement, risk of recurrence in parameter involvement is less than 1%. So that is the reason why now in simple trachelectomy the parameter is not taken off as we do in radical trachelectomy.
What is the inoperable stage of cancer cervix? Inoperable.
Sir, we can operate the patient till 1B2, and also 2A sometimes 2A is operable, but if the patient's tumor size is greater than 4 centimeter or greater than 2A stage, we cannot operate usually we do not operate C.
Any role of exentration in the present era? Exentrations.
Sir, currently we do not usually prefer doing exenteration because it hampers the quality of life which is being experienced by the patient after exenteration. But if the only indication is that if the patient has come to us with recurrence, and that too central recurrence only, that is up to 1B. That is up to 2A, which less than 4 centimeter. In that case only we can go with anti exenteration. Otherwise pelvic exenteration is currently not the treatment of choice.
Rajat, what is palliative care or palliative treatment? Palliative care.
Ma'am, palliative thing is a situation in the patient life of a cancer patient where we cannot give any other treatment or we cannot do surgery of the patient. So that is from the just taking care of the symptomatic care of the patient. If the patient is feeling any symptom, we could give her just symptomatic treatment. Usually, ma'am, systemic chemotherapy is given in palliative care, ma'am, because it reduces the load of the load of the tumor, which will improve the quality of the patient, quality of life of the patient. And the dual drug therapy is used. Paclitaxel and cisplatin, two drugs are used in the palliative care of the patient. And it is used when the tumor size, if the patient is having the hydronephrosis or the tumor size is greater than 3 centimeter. And one more thing. That's it, ma'am. That's it.
So very nice presentation, Rajat.
Thank you so much.
Yeah, I think very well presented, well discussed.
Yes.
Best of luck for your whatever, I don't know. You are in third year, I think, and you are doing very well.
Yes,
Read more, score more. Okay. Chalo, okay. From my side, it's over. Okay. Very well done.
So all the best, Rajat, and hope you do good during your exams.
Thank you.
And Rajat, for an additional information, I would like to tell you, recently WHO has introduced a program, WHO Cervical Cancer Elimination Program. So it was introduced in 2018. The target was 90, 70, 90. 90% vaccination, 70% screening, and 90% treatment. So recent advances, they might ask you. So thank you, judges, for the very important topic and having patience and bearing all the technical hitches. Special thanks to Bangal sir, Monica madam, and Anuja ma'am, finally coming in the end and helping us out. So thank you all.
Thank you very much. Yeah.
Thank you.
Thank you.
Now we will shift on to our last. We had a table viva. We could not complete because again with the technical hassle. So I invite Dr. Seema Parvekar ma'am and Tuhina. We will have the table viva on that. For 10 minutes it will be because we are already running short of time. Next person, case presentation, Dr. Kannan, please be ready. Seema ma'am, can you hear us? Yeah. Should we begin with the Tuhina? Please unmute yourself. Sanjita, could you please unmute Dr. Tuhina and Dr. Seema ma'am?
Okay.
Sanjita, could you please unmute Tuhina? Seema ma'am, we can't hear you. Please make co-host to Tuhina. Tuhina, can you hear us?
Yeah. Hello, good afternoon.
And Seema ma'am? You're still not audible, ma'am. Okay, we'll wait for a minute. Yeah. Tuhina?
Yes, ma'am.
Are you prepared? Can you guess any questions from the slide?
what are the uses of the devices shown in the picture.
But I have a surprise. There is a different slide. This is just a trailer. Till we wait for Seema ma'am to take her technical things. Okay, ma'am, we are really sorry. We are running late by an hour. So
Can you hear me?
Yeah. You are audible. A little louder, ma'am. It will be perfect.
Tuhina, can you please describe this device?
Good afternoon, ma'am. The following devices shown in the picture are long-acting reversible contraceptives, the intrauterine devices used. The first one is they all are copper Ts, and the first one is copper T 380. The second one is copper T 375, also called the multi-load 375. And the third one is the newer version, the Nova T, which they are used for contraception. The main mechanism behind this is the T shape is used. It causes inflammatory changes in the endometrium, which prevents fertilization and implantation. The copper, which is associated with it, increases the inflammatory process, and basically it is going to prevent the fertilization. It's spermicidal as well as ovicidal, and also cause the thinning, does not allow the implantation of the zygote. And the multi-load, there are three, the
375.
The 370, the multi-load has it is an advanced version of the copper T, which we use. The mechanism of action is similar, except the loading, which the method of insertion is different. Here in the copper T,
which method is used for the 380A?
It's the withdrawal method,
Yes.
where we have a plunger and we have for inserting. And in the multi-load, it's self. We are not supposed to. We don't need to load the device. It can be directly inserted. And the Nova T as well. The Nova T, here again we don't need to load it, but we need the plunger is pushed, the proximal end, which has a thread. The plunger is held and pushed in the distal end, so that it is withdrawn inside. And basically all three require different methods of insertion.
What is the period of 380A?
It's 10 years now. 10 years
And,
for 380. For 375, it is 5 years. And for Nova T as well, 5 years.
Okay. When the fertility is returned after the copper T insertion?
Immediately.
Pardon?
The fertility returns immediately after removal of copper T.
Okay. Up to the 6 months it will be returned. Which are the benefits of this one copper T 380A?
380 benefits over the other ones, ma'am?
Yes.
So the copper T 380 has the arms. So copper is loaded on the arms as well. And
it is a highly effective and effective immediately after the insertion, and suitable for use by the most of the women.
and safe for
It's
the use in breastfeeding women also.
Yes, ma'am.
Okay.
And under the scheme of national welfare, it's included copy is available. Rest the others are supposed to be bought. It's not included in the national program.
When the
Can we have
property
the
insertion is
question on the
done?
next slide? We have just 3-4 minutes more.
Okay, madam. Which is the device?
It's a self-retaining catheter, Foley's catheter, 40 centimeter in length, and it's usually it is made up of 3 types: latex, propylene, and silicone. It is of various sizes. Depends. It's called the sizes are given in French, from 8 French to 30 to 18 French, which is available here. The French is the external diameter. It's the French given is to be divided by 3. That gives the diameter of the external diameter in mm, and it has various uses. It's used basically to mainly for catheterization, urethral catheterization of women, and in high risk pregnancies, in patients where urine output is supposed to be monitored, or in patients who are under anesthesia who cannot be mobilized immediately. So preoperatively patients are catheterized, and it also has other obstetric uses and gynec uses. In obstetric uses, there are it can be used for inductions, like in second trimester MTPs. In second trimester inductions, for termination, it can be used. Then even for a full term in inductions, for 18 French is used, and the bulb is inflated with 60 to 80 cc of NS. And it is when it is available in doubly sterile pack, and it is in for gynec uses. It is patients with huge pelvic tumors, who have urinary blocks, who can be catheterized. Then patients with in certain procedures like myomectomy, where smaller size of Foley's catheter is used, around 8 to 10, for just at the internal os, intrauterine, just at internal os, to inflate and to know whether we have reached the cavity during the procedure, in case while removing the myomas. And
can we use it in PPH also?
Yeah, it is used when the UBT, the uterine balloon tamponades, are not available in emergencies. We can use the Foley's catheter, which is available, 18 French, and with a condom, and we can tie the condom at the distal end and inflate with 200 after inserting in the intrauterine. After intrauterine insertion of the placement of the condom, we can inflate it for the tamponade effect.
What is the capacity of balloon?
The balloon of the Foley's catheter, which is it depends on the size of the catheter. In 8 to 10, it is 5 to 7 cc in catheter as it goes. In 18 French, capacity is up to 80 cc, and
so we use in PPH the 24 number of catheter, and it may be up to the 50 ml and above capacity. Then another use of the Foley's catheter in the gynae. Is there it is used in bladder injury, and how many days you can keep the catheter?
Yeah, when there is a suspected small vesicovaginal fistulas, we can keep a catheter for 4 weeks. When we are expected to keep for 3 to 6 weeks, and we can use another silicone catheter for that, because it is an inert product, and it with decreased chances of UTI with the silicone one. And where we require to put where we require to catheterize a patient for a longer time.
nicely presented the instruments, but we have a very little time. And thank you very much.
Thank you, ma'am.
Thank you, Seema ma'am. Thank you, Duhina. It was a very nice session. It was a very short and sweet session.
Yes.
Thank you, ma'am.
We'll move towards our next case. So for our next case of secondary amenorrhea, we have with us Dr. Kanan from JNMC Savangi. Faculty members are respected Dr. Shailesh Kore, sir. Welcome you, sir.
Kanan, just hold on.
Yeah, I am there. Can you hear me? Hello? Hello?
Hello.
Hello?
Yeah. Kore, sir, he's a UG-PG teacher since 28 years. He has lots of publications to his credit. He has many awards and prizes in his bag. Welcome, sir. Dr. Pazai, ma'am. She is a professor in OBGYN at Savangi Meghi Institute. She has lots of national and international publications with a huge 30 years of teaching experience. She has contributed 3 chapters in the book. Welcome, ma'am. Madhuri Patel, ma'am, she is assistant professor at IGGMC Nagpur. She has a teaching experience. She has a huge teaching experience. She is a PG guide and has lots of national and international publications. We welcome you, ma'am. Over to you, Kanan. You can start sharing
Yes,
your
ma'am.
screen.
Okay. A very good afternoon. Can everyone see my screen?
Yes, we can.
Yes, your screen can be seen.
Yes. Yes. A very good afternoon, everyone. My case is on secondary amenorrhea. So, Shivani Lohane, a 22-year-old unmarried woman, Hindu by religion, telephone operator at call center by
Kanan,
occupation,
can you please
belonging to
start your
middle.
video?
Sorry, ma'am. My video is on.
Yeah, please continue.
Continue. Okay. Telephone operator at call center by occupation, belonging to a middle-class family residing at Devli, Varda, visited OPD of AVBRH with complaints of amenorrhea for past 8 months on 6th January 2022. Her chief complaints were amenorrhea for past 8 months, acne over face for past 1 year, and complaining of weight gain over past 2 to 3 years. Patient was apparently all right 3 years back when she started to experience weight gain over time and also experienced acne over face, which were increasing now. She had irregular menses along with scanty bleeding for past 3 years, and since 8 months she is having amenorrhea. She visited doctor twice in her local place in the past, but was non-compliant for the treatment and no documents were available. Menstrual history. Age of menarche was 13 years of age. Last menstrual period was 8 months back. She didn't know the exact date, but it was in the month of June 2021. Cycle since past 3 years were 1 to 2 days with intermenstrual period of 30 to 90 days. Irregular. It was reduced flow of 1 pad per day. Dysmenorrhea and clots were absent. In past cycle, before the 3 years, it was 3 to 4 days long. Intermenstrual period was of 30 to 32 days. Regular and average flow of 2 to 3 pads per day. There was mild dysmenorrhea and clots. There were no complaints of clots. She was unmarried and sexually inactive. No history of fatigue, cold sensitivity, constipation, swelling in the neck was seen. No history of galactorrhea, no history of headache and visual symptoms. No history of fever, chronic cough and night sweats, and no history of major illness in the past. No past history of diabetes, hypertension, TB, asthma, thyroid disorder, or epilepsy. No history of any medical or surgical illness. No history of any allergic reactions were present. Family history of diabetes mellitus was there in her maternal grandfather. She didn't know exactly what anti-diabetic medication he was on. No history of hypertension in any family members. No history of any all the siblings and maternal cousins had normal menstrual cycles and fertility. Personal history, she was on mixed diet, regular bowel and bladder habits, normal appetite, no history of any intake of any hormonal or antipsychotic medications, and no history of any alcohol or any addiction. On general examination, patient is well oriented.
From the history, what is your probable diagnosis? What can be a cause of her amenorrhea?
Ma'am, as polycystic ovarian syndrome is the most common cause of secondary amenorrhea in this age group, and with the appearance of the women and history of acne and giving history of weight gain of around 10 kg in past 2 years, you can suspect of polycystic ovarian syndrome as a cause of her amenorrhea.
Anything else you
And
would like?
because she, hello.
Yeah, madam, continue.
Ma'am, because also she is sexually inactive and unmarried, we had ruled out pregnancy also, which is the most common physiological cause of it.
Okay, means that is not a criteria that unmarried and sexually inactive by history.
Yes, ma'am.
So first thing,
Yes, ma'am.
always you have to rule out, particularly if it is a
Pregnancy.
7-8 months amenorrhea, you have to rule out the pregnancy. Yeah?
Yes, ma'am. Yes.
Okay, go ahead.
Okay. On general examination, patient is well oriented to time, place, and person. She was well built and well nourished. Her height is 160 centimeter, weight 76 kg, which came to BMI of 29.6 kg per meter square. Waist circumference was 89 and waist hip ratio was 1.1. Patient was afebrile, pulse was 82 per minute regular. BP was 110 by 70 millimeter of mercury. There was no pallor. Facial hair were of normal grade with Ferryman-Galway score of 5. Acne were present on face of moderate severity. Acanthosis nigricans was seen over nape of neck, which was of mildly present. There was no thyroid swelling or lymphadenopathy and normal secondary sexual characteristics, and there was no galactorrhea. On systemic examination, on cardiovascular system, S1 and S2 were heard. There were no murmurs present. On respiratory examination, bilateral air entry were equal and no adventitious sounds were heard. On breast examination, it was normal with no galactorrhea. On per abdominal examination, on inspection, apple-shaped fat distribution was central obesity was seen with stretch marks. Shape and location of umbilicus was normal. No evidence of scar, lump, or engorged veins was seen. On palpation, it was soft, non-tender, and no organomegaly. On local examination, external genitalia were normal. As ma'am, in our country, we don't prefer to do per vaginal or per speculum examination of women who are not sexually active. So we had not done PS or PV examination. My provisional diagnosis, a 22-year-old unmarried girl with secondary amenorrhea since 8 months, probably due to polycystic ovarian syndrome, which should be confirmed after investigation.
So what are the tests you should do in this woman to confirm your diagnosis?
Yes, ma'am. Ma'am, first of all, we should perform UPT to rule out pregnancy in these women, as ma'am saying. Then, ma'am, we will go forward with first serum TSH levels and serum prolactin levels. For the diagnosis of exclusions, and then ma'am for confirmation of PCOS.
How TSH is important?
Ma'am, for hypothyroidism, to diagnose hypothyroidism, because
how hypothyroidism causes amenorrhea?
Ma'am, because of hypothyroidism, there will be a TSH increase. Increased TSH will cause GnRH to decrease reflexly, and this GnRH will ma'am have same effect. LH will be increased. So it has the same hypothalamic pituitary imbalance which is there in PCOS. And ma'am, same will happen in hyperprolactinemia also. In that, because of prolactin increase, there will be reflex dopamine increase will be there to reduce prolactin, and it will also have same effect on GnRH, and LH will be increased.
Okay. Okay, good.
Ma'am, then we will do the ma'am for this ma'am progesterone challenge test is done. Then
before going to progesterone challenge, can you go for the ultrasonography?
Yes, ma'am. Yes, ma'am.
What is the importance of
That was
ultrasonography?
Ma'am, ultrasonography is one of the diagnostic criteria for PCOS. So to see the ovaries, we do the USG. Ma'am, for the diagnostic criteria, it is more than or equal to 20 follicles should be there of 2 to 9 mm size in ovary, and the ovarian volume should be more than 10 ml cube.
Is ultrasound really necessary for now diagnosis of
No,
PCOS?
no, ma'am. No, newer ASHRAE guidelines of 2018 says if there is hyperandrogenemia and the features of irregular menses, amenorrhea or oligomenorrhea, we can. It is not necessary to do USG for confirmation of PCOS.
Yeah, but anything else apart from seeing the ovaries you want to see when the patient comes with amenorrhea?
Yes, ma'am.
Or you want to only see the ovaries only?
No, ma'am. We will see for the uterus. We will also see the uterine condition. Also, the PID should be ruled out.
On ultrasound, how you will?
On ultrasound, how will you rule out
No,
PID on ultrasound?
No, ma'am.
Anything about endometrium?
Yes, ma'am. The endometrial thickness should be same. Because, ma'am, if there is any premature ovarian insufficiency or anything, so basically the estrogen primed endometrium is there or not.
So what at present if you are suspecting a PCOS, what type of endometrium you are likely to get on ultrasound?
Ma'am, estrogen primed endometrium.
Yeah, means that on ultrasound you can't say that it is estrogen.
No,
primed.
ma'am. Ma'am, endometrial thickness. Yes, ma'am. Only we can.
So what type? It will be less, more, or
endometrial hyperplasia or atrophy? What is that?
Ma'am, there will be hyperplasia. Ma'am, there will be hyperplasia.
Hormonal estimation you can do for diagnosis.
Sorry,
Any
hello.
can be done for diagnosis of PCOS.
Ma'am, your voice was breaking. Sorry, hormonal test.
Yeah, you can newly added
Yes, ma'am.
investigation for PCOS.
Yes, ma'am. We can do estradiol levels, LH levels, and LH-FSH ratio we should count. And testosterone levels also.
How it will
testosterone levels.
How?
What are the
Hello?
cutoff levels? Means what you are basically want to see by
Yes,
these
ma'am.
hormones?
Yes, ma'am. For testosterone levels, more than 20 to 80, it is okay for PCOS. If it is less than 20, it is in normal limits. If it is more than 200, then we should rule out any ovarian tumors. Then for LH-FSH ratio, if it is more than 3/1, then we can say it is one of the diagnostic factor for PCOS.
Is it really required to do FSH-LH for PCOS diagnosis?
No, ma'am.
How is it going to change your management if by checking the FSH-LH levels?
Ma'am, if we are planning to give combined oral contraceptive pills, it will also help to reduce LH levels. So basically, the plan of medical management can depend on LH levels also.
But if the LH level is less and suppose the patient has irregular menses, her main complaint, and she has acne, you will not give oral contraceptives.
No, ma'am, we will give, but it will have additional benefit.
So it actually does not make any real difference in diagnosis or management.
Okay, ma'am.
Okay, what madam was asking, what are the other hormones which with the cutoff levels you will look for?
Ma'am, hormones, ma'am, there will be 17. Hi.
Anand, do you do AMH level?
Yes, ma'am, we will do AMH also. Ma'am, AMH is now considered, they have proposed to include it in diagnostic criteria also. If it is more than equal to 5 nanogram per ml, then it can be diagnosis of PCOS. It is not
Okay.
yet included in it, but it is proposed to be included.
Yeah. Go ahead.
So what now you said about the progesterone challenge days? How you will do the progesterone challenge test?
Ma'am, everyone have different methods. If we medroxyprogesterone acetate is given 20 mg for someone give 5 to 7 days or 7 to 10 days, and then again wait for 1 more week. So total after 14 days, we will ask patient to come. If there is a withdrawal bleeding is there, which is not called as menses, it is a withdrawal bleeding. If it is present, then we can say that the endometrium was already primed with estrogen, and we have given. So we can say
normal
that
menses is withdrawal bleeding or it is a breakthrough bleeding?
Ma'am, it is a breakthrough bleeding.
Normal menses is breakthrough bleeding.
Sorry, ma'am, it is withdrawal. Sorry, sir.
It is
Ma'am,
also withdrawal only, na?
Yes, ma'am.
What get withdrawn?
Sorry, ma'am. Progesterone, ma'am.
So even the normal menses is also withdrawal bleeding only. Type of
Yes,
withdrawal.
yes, ma'am.
Okay.
Yes, ma'am.
Okay. Then, so suppose she doesn't bleed, then
ma'am, we will go for estrogen plus progesterone challenge. So
how you
basically
give
now
that?
Hello. Yes, ma'am.
How you give that estrogen plus progesterone?
I can't get the question.
Which drugs you give and what is the dose?
Ma'am, yes, ma'am. Ethinyl estradiol will be given.
You give ethinyl
with,
estradiol regularly?
No, ma'am.
Normally, it is given conjugated estrogen. That is more.
Yes, ma'am.
Something like a Primarine or something. Given in 1.25 milligram for 21 days, and then last 5 or 10 days you add medroxyprogesterone.
Yes,
and then wait for another. Okay, so do you expect a positive withdrawal bleeding after progesterone challenge or no in your patient?
Yes, ma'am. We will expect a withdrawal bleeding here.
Why?
Ma'am, because in here we don't have any pathology at hypothalamus or pituitary level, so our endometrium is already have estrogen present. So I will expect withdrawal bleeding after progesterone.
It's not endometrium. You are already, your clinical diagnosis is PCOS, no?
Yes, ma'am.
Obviously, it is a estrogen prime endometrium with the absent progesterone. So you will expect a bleeding with the progesterone.
Yes, ma'am.
Suppose there is no bleeding with estrogen progesterone, then?
Ma'am, if there is no bleeding with estrogen and progesterone, then it will be it can be a cause of uterus like local origin, Escherman syndrome or synechiae will be present.
Or
anything in
Ma'am.
You are mute.
No, ma'am. Hello. Hello. Yes, ma'am. Ma'am, Escherman syndrome and
so basically the outflow tract. Okay?
Yes, ma'am. Outflow tract will be.
And if it is, if the patient bleeds with the estrogen progesterone, then what does it
Ma'am, again we should actually do one more test of FSH, and if FSH is increased, then if FSH comes in
increase means what? How much it should be?
Ma'am, more than 40 milligram.
Yeah. Okay.
Then we can say that it is premature ovarian insufficiency or failure. And if FSH is reduced, then we can say that because there is some involvement of hypothalamus level, or so because of, then we should rule out that causes of stress or weight loss or anything. And for any pituitary causes, we should do MRI if there is any prolactinoma or pituitary tumor.
Okay, so now on suppose with progesterone challenges the patient is bleeding, then how you are going to further evaluate and manage?
Yes, ma'am. Ma'am, first we will have to ask the patient about what is her issue. Like in this patient, there is no issue of infertility right now. So now on the guidelines say, ma'am, we should first go with the lifestyle modifications. with weight loss of around 5 to 10% and overall exercise and healthy diet. And with that also, if she will, and ma'am, for the treatment of acne, we will give acne treatment and lifestyle modifications. We will wait for some time of around 3 to 6 months. And if
So how
she
will you
will not
ensure
be,
that she loses weight?
ma'am,
You can't
it
just
is
tell that
just,
you lose your weight. You have to just tell her
no,
properly.
ma'am. Yes, ma'am, we have to counsel her. And yes, ma'am.
Will you take a help of dietitian or some nutritional specialist?
Yes, ma'am. And with weight loss also, she should be often not a unhealthy weight loss. So dietitian should be consulted for healthy diet. And also she should be counseled for at least 30 minutes of exercise every day. We can just tell her to brisk walk if she doesn't have any other facilities available. She should also have a regular lifestyle, should also not be very sedentary. If with all this, we will wait for some time, and if she is non-compliant or with all this compliance also, if she continues to have amenorrhea, then ma'am, we can shift her on oral contraceptive pills. But ma'am, we should also counsel that if we will give drugs, then it will be just a temporary solution. So first she should concentrate on her lifestyle modification.
Why it is called polycystic ovarian syndrome? Syndrome means you do you want to see something else also in the investigation?
Yes, ma'am. Because we should see in any insulin resistance is there.
So how will you see that?
Ma'am, we should do fasting insulin and fasting glucose also. And there is also homeostatic, ma'am, HOMA index is also there for fasting glucose into fasting insulin upon 405. If this index comes more than 5, then it is diagnostic of insulin resistance.
Anything else in syndrome apart from insulin resistance? You all also want to, because she is so obese.
Dyslipidemia should also be ruled out. Basically, when the metabolic syndrome things like decreased HDL and increased triglycerides of more than 150 and HDL of less than 150 at the cutoffs.
Does your patient has hirsutism?
No, ma'am.
What is mean by hirsutism?
How you define?
Hirsutism is the growth of hair over
judges, we have 5 more minutes.
Yeah.
Kore sir, could you please summarize the case for the students?
No. I just want to ask her, Kanan, na? Yeah.
Yes, ma'am.
So apart from that, what you are going to give her? How you are going to manage this patient? Suppose she has her insulin resistance comes positive. Her main complaints are the irregular menses and acne. So what treatment you are going to give?
Ma'am, if insulin resistance comes positive, then we should positively think of metformin. Currently also, ma'am, metformin is now not a first line drug, but still in practical purpose, we are giving it and it has good results. So we can start her on metformin.
So that will not treat her, acne.
Yes, ma'am. For acne,
which oral contraceptive you prefer in this patient?
Ma'am, we will give combined.
Because she has a hyperandrogenemia, na?
Yes, ma'am.
To which oral contraceptive?
Ma'am, we will give combined oral contraceptive only.
Which type means madam is asking you which, there are so many oral contraceptive, any particular oral contraceptive containing something which will
is the What
Ma'am,
is the content in that drugs? In that
ma'am,
oral content, what will be the drugs?
ma'am, hydroxyprogesterone acetate.
Cyproterone acetate.
Ceproterone, yes, ma'am. Ceproterone acetate has
any
also effect on
contraceptive,
aromatism.
any oral contraceptive contains hydroxyprogesterone acetate, you know?
No, ma'am, it is just a single cyclic progestin. Sorry, ma'am.
So yeah, no OC pills contain medroxyprogesterone acetate.
Yes, ma'am. Yes, ma'am. Sorry, ma'am.
Thank you all. Thank you, judges. Thank you, Madhuri ma'am.
Thank you, ma'am.
Thank you, Kore sir.
Yeah.
Thank you, Bajay ma'am.
Thank you, Prachi
Kanan,
and all other.
you're so gracious to Kore sir. He kept on listening to you, ma'am, but he did not interrupt you even once, so that you don't lose your confidence. Thank you, sir.
Okay.
Thank you so much, sir.
Thank you, sir.
Now we move on to our next session. It will be a case presentation by Dr. Neha Anand. And we have the judges, Dr. Gadappa, Dr. Aparna Vahane ma'am, and Dr. Nikita Vijay ma'am. Let us first read out the CV once. I welcome Dr. Gadappa, sir. He is professor and HOD, Department of Obs-Gynae, Government Medical College, Aurangabad. Sir has been a master trainer for Lakshya NHMGO, Government of India. He's been a master trainer at CAC. Sir has written various books and publications. He was the first to start respectful maternity care in government hospital with White Ribbon Alliance. Sir has been member of various national and international bodies. I welcome you, sir.
Thank you.
Next on board, we have Dr. Aparna Vahane ma'am. She is professor and HOD Obs-Gynae Department, GMC Akola. Ma'am has been, she has a vast teaching experience of more than 25 years. She has been MUHS approved UG and PG teacher for obstetric and gynec. She is approved fellowship courses in minimal access laparoscopy surgery and gynae in her medical college for 4 seats. She's been member of MET and ethical committee. Welcome you, ma'am. Then I also welcome Dr. Nikita Vijay ma'am. She is associate professor in the Department of Obs-Gynae NKP Salve Institute at Lata Mangeshkar. Madam has various publications in national and international journal. She has completed her basic medical courses, education courses, basic research methodological courses. She has training in gynec, endoscopy, infertility, and she has also received training in FOXY PPIUCD. Ma'am has special interest in recent advances in obstetric and gynec. I welcome all the judges. Neha, you can start sharing your case.
Yes, ma'am.
Sanjita, please make all the judges.
Good evening, everyone. Today I'll be presenting case on multifetal pregnancy.
Neha, am I audible?
Yes, sir. Yes, sir.
Is it a real case or a virtual case?
No, sir. It is a real case.
Okay. Start.
An XYZ pregnant woman, 33 years old, housewife by occupation. Husband is a daily laborer, resident of Savangi, educated till 10th standard. Husband also educated till 10th standard. Hindu Kunbi, belonging to upper middle class according to Prasad's classification. Visited to our labor room at 4 a.m. on 14th of February 2022 as an emergency patient with history of amenorrhea since 9 months and chief complaints of pain in abdomen since 2 hours. Moving forward, patient was apparently all right 2 hours back when she started having pain in abdomen, which was sudden in onset, gradually progressive, radiating to back with no aggravating and relieving factors. Fetal movements were perceived well. There is no history of trauma to abdomen, no history of leaking per vagina, no history of bleeding per vagina, and no history of headache, vomiting, blurring of vision, or edema of the feet. First trimester, it was in spontaneous conception. UPT was done after 8 days overdue at home and pregnancy was confirmed. first ANC visit at 12 weeks at nearby PHC. Soon after the confirmation, she was started on folic acid supplements. USG was done at 12 weeks, which was suggestive of twin pregnancy with mean gestational age corresponding to 11 weeks and 3 days. Patient was counseled and advised abstinence and not to lift heavy weight. Blood and urine investigations were normal, and there is no history of pain in abdomen, bleeding per vagina, excessive vomiting, radiation exposure in first trimester.
Neha,
Yes, ma'am.
your patient took the folic acid at 12 weeks.
Yes, ma'am.
Yes. What is your opinion whether this was the right time to start or what? Because patient came to you at 12 weeks, that's why you started at 12 weeks. But what is the ideal?
Ma'am, ideal timing, the folic acid should be started as soon as early as possible, because in twin pregnancy, generally the female is at a risk of developing dimorphic anemia rather than in singleton pregnancy, ma'am.
What is the rationale behind starting the folic acid? And what is the ideal time to start the folic acid during pregnancy?
Ma'am, ideally it should be started as soon as the pregnancy is confirmed, and if it is confirmed in early gestation, it should be started after after confirming the viability of the pregnancy, that is after appearance of the cardiac activity, that is 6 to 8 weeks, 6 weeks, ma'am.
Folic acid, we have to start periconceptually. Ideally,
3 months earlier, ma'am. Yeah.
one month prior to the conception.
Okay, ma'am.
The rationale behind giving the folic acid to prevent the neural tube defect in the fetus. So what is the time, at what time the neural tube formation happened?
Ma'am, around 11 to 13 weeks. The best time to diagnose it as on ultrasonography is 11 to 13 weeks, ma'am.
So at 6 to 7 weeks, neural tube fusion happens. So ideally, we should start the folic acid as early as possible or prior to the conception to the patient. Okay, one thing. Second thing, your patient has done the sonography in the first trimester at 12 weeks.
Yes, ma'am.
That was the best time to perform the USG, especially in the multiple pregnancy.
Yes, ma'am.
What are the 4 information you can get from this ultrasonography at 12 weeks? And what are the parameters missing in your patient?
Ma'am, the 4 important things that should be noted during the first scan, that is, it helps in confirming the date, the gestational age of the patient, the amnioticity and the chorionicity of the pregnancy, then the knuckle translucency. It helps, it is important to see that also, and the Doppler, ma'am, the ductus venosus study is also important during the first trimester.
Okay, there are 4 things we have to see in the first trimester scan, that is between 10 to 13.6 weeks. That one is gestational age by the CRL. Second is chorionicity.
Yes, ma'am.
And third is orientation of the pregnancy. For the orientation, we have to give the maximum information at this point of time. Okay. And this should continue with the same orientation all throughout the pregnancy. And fourth thing is aneuploidy screening. For that we do the NT scan and the NT and NB scan at that time. So these 4 things we have to do ideally between 10 to 13.6 weeks time. This is the best time.
Yes, ma'am.
Okay.
Ma'am, should I continue?
Yes.
There was no history of pain in abdomen, bleeding per vagina, excessive vomiting or radiation exposure in first trimester. Moving on to second trimester, the patient felt quickening and 5 months of pregnancy. The dose of injection TD received at 4th and 5th months, took iron, folic acid and calcium supplements. USG was done in second trimester, around 20 weeks, suggestive of dichorionic diamniotic live intrauterine fetus with growth appropriate for gestation of 22 weeks and without any congenital anomalies. No history of pain in abdomen, bleeding per vagina, leaking per vagina, and no history of headache, pedal edema, blurring of vision, or decreased urine output. Then moving on to third trimester, the patient perceiving fetal movements well, took iron and calcium supplements. USG was done at 30 weeks, suggestive of DCTA twins. The first twin being the cephalic. Male gestational age is 29 weeks, 1 day. Weight is around 1.7 kg with cord around neck. The placenta is anterior and AFI is 14.8 centimeters. The second fetus is also cephalic, corresponding to mean gestational age of 27 weeks and 6 days with a weight of 1.4 kg, placenta posterior, and AFI is 9.8 centimeters. No further USG were done and patient is presented with the above mentioned complaints in emergency to our hospital. Blood and urine investigations were repeated, which were normal. No history of headache, pedal edema, blurring of vision, and facial puffiness, and no history of pain in abdomen, bleeding PV, leaking PV, or discharge per vagina. Moving forward to menstrual history, patient attained menarche at age of 13 years. Her past menstrual cycle were regular, coming every 28 to 30 days. Bleeding was normal, lasting to 3 to 4 days without dysmenorrhea. The last normal menstrual period was 12th of June 2021, and according to the LMP, the expected date of delivery is 19th of March 2022. So the calculated gestational age was 35 weeks, 2 days by Nagel's rule, and no history of use of any sort of contraception in the past. Moving on to obstetric history, the patient is primi gravida and married since 2 years, and marriage was non-consanguineous. No history of use of any ovulation-inducing drugs or assisted reproductive techniques. No history of medical major illnesses like hypertension, diabetes, tuberculosis, asthma, thyroid dysfunction, or drug allergies. No history of any other operative intervention. Family history, history of twin pregnancy on maternal side. No history of medical illness like hypertension, diabetes, tuberculosis, or asthma. Dietary habits, the patient is vegetarian with having adequate appetite, 8 hours of sleep per day, unaltered bowel and bladder habits, no history of addictions. Dietary history is total calorie intake is 2,500 kilocalories per day, and total protein intake is 60 grams per day. On general examination, patient is conscious, cooperative, oriented to time, place, and person, moderately built and nourished. Blood pressure is 126 by 84 millimeter of mercury, taken in right arm in sitting position, and pulse is 82 beats per minute, regular, good volume, bilateral synchronous, without any radioradial and radiofemoral delay. Her height is 154 centimeters, and her present weight is 64 kgs, and first antenatal visit weight is 46 kgs. So the weight has been increased by 18 kgs. Therefore, the current BMI is 26.9 kg per meter square. Her gait is normal. Pallor present over.
Neha?
Yes, ma'am.
What is more important, whether it's a pre-pregnancy BMI or the pregnant BMI at that time that you are examining the patient?
Ma'am, the pre-pregnancy BMI is also important because it has been the variability has been seen that the risk of twin pregnancy is more in taller and obese person than in malnourished and undernourished women, ma'am.
Pre-pregnancy BMI determines the weight gain during the pregnancy.
Yes, ma'am.
And for the multiple twin pregnancy, how much is the recommended weight gain in a patient with the normal BMI?
Normal BMI, ma'am, there is a range of weight gain that extends from 18 kgs till 24 kgs, ma'am.
18 to 24 kgs. Okay, 62. Okay, it's fine. Okay. What will be your dietary advice to a patient who is having the multiple pregnancy?
Ma'am, in multiple pregnancy, surely the dietary requirement is increased during multifetal gestation. The carbohydrate, fats, and proteins, they are taken in a ratio of the carbohydrates are told to take at a 40% of the total diet. It should contribute the 40% of total diet. Then the fat should also contribute the 40% of the total diet, and protein contributes 20% of the total diet. And there should be frequent small meals in between. It should constitute 3 major meals with 3 frequent snacks in between.
Calorie intake is 40 to 45 kg.
Yes, ma'am. Yes, ma'am. Calories 40 to 45 kilocalories per
kg per day.
Yes, ma'am. Her gait is normal. Pallor present over lower palpebral conjunctiva and the oral mucosa. No clubbing, cyanosis, icterus, or lymphadenopathy. Thyroid gland not palpable. Both the breasts are normal. Nipples and areola normal. Respiratory system bilateral air entry equal with no additional sounds. Cardiovascular system heart sounds are normal and there are no murmur.
Neha, as far as multiple pregnancy is concerned, what is more important, whether it's the chorionicity or it's the zygosity?
Ma'am, the chorionicity is more important than zygosity, ma'am.
Why?
Ma'am, because when compared the dichorionic pregnancy with monochorionic pregnancy, the perinatal outcome, mortality, morbidity, and complications are more commonly reported in monochorionic pregnancy, ma'am.
And what is the best time to determine the chorionicity during the pregnancy?
Ma'am, during 9 to 12 weeks of gestation, ma'am. Just after the formation of the chorion, that is after 8 weeks, ma'am. But the best time is 9 to 11 weeks, ma'am.
Yes. This is 10 to 14. Ideally, we should determine the chorionicity before the 14 weeks. Okay? 10 to 14 is the ideal time. What are the various measures to determine the chorionicity in the ultrasonography?
Ma'am, in ultrasonography, there are 3 main points which has to be noticed. The number of placental masses that we are coming across, then the thick band that is separating the two sacs, the number of amnion and chorionic membranes, ma'am, and
yes, continue.
Yes, ma'am. Moving forward, on per abdomen examination, on inspection, abdomen is over distended, flanks are full, umbilicus is central and everted, stria gravidarum and linea nigra seen, no previous scar, dilated veins or sinuses are seen. On palpation, the symphysiofrontal height is 38 centimeter and abdominal girth is 102 centimeters, multiple fetal parts palpable and 3 fetal poles are palpated. On auscultation, 2 distinct fetal heart sounds heard. One is heard on left spino-umbilical line. The rate is 130 beats per minute. And the second one is just below the umbilicus on right side, 146 beats per minute. On per speculum examination, the os is closed and the cervix and vagina appeared healthy. And on gentle per vaginal examination, the cervix is undilated and unfazed.
But os is closed, but what is the length of the cervical os?
Ma'am, on digital examination, it was approximately, ma'am, around 2.3 to 2.2 centimeter, ma'am. 2 to 2.2 centimeter.
Why do you think we are asking this? What is the importance?
Ma'am, because cervical length, if it is less than 2 centimeters, it fits into the criteria that she may land up in preterm labor. Generally, the cervical length is important for that, ma'am. If the mean value is, ma'am, 2 centimeters, if it is less than that, the chances of preterm pain or preterm delivery, the chances are more, ma'am.
Yeah, there are more here, but more so in case of twin pregnancy, rather, we can say. Why? Why the cervical length becomes reduced here? What is the mechanism of action? It is not because of the increase in collagen or anything like that. Usually the causes for cervical insufficiency mostly are different causes, like biochemical causes, other causes. But for here, what is the cause here for decrease in cervical length?
Ma'am, because of the pressure effects of the weight of the babies and
It's a
increase in liker, ma'am, in twin pregnancy.
Yeah. So mostly the reason is because of mechanical. It's a mechanical thing.
Compression.
Yeah.
Yes.
The increase in the volume of the amniotic fluid and also the
Weight of
of both the fetuses. It is giving a mechanical pressure over the os. That's why the cervical cervix is also taken up a little bit, and there is a decrease in the cervical length.
Yes, ma'am.
Okay. Next.
So my provisional diagnosis is 33 years, primary gravida. Period of gestation is 35 weeks and 2 days with dichorionic diamniotic twins with preterm pain.
Okay, she is in preterm.
Yes, ma'am, because she was presented 35 weeks, 3 days, ma'am. This is the mean gestational age at which the twins can present with pain, ma'am. So she was having a sudden onset of pain, which was gradually radiating to back and with no aggravating and relieving factors. So yes, we can say that she is presented with preterm.
Neha,
Yes, sir.
before we proceed, I have got two issues in the history. One is you said that the classification, socioeconomic classification you did with Prasad classification.
Yes, sir.
And you are not used Kupuswamy classification. So what is the logic behind that?
Sir, we can use either of them. I preferred using Prasad.
But internationally, when we are publishing papers, it should be uniform. So what are the advantage of Prasad classification or Kupuswamy classification?
Sir, the criteria that is being used in Prasad classification is only one criteria, that is the only monthly income, the monthly income per person. So it is easier to calculate. Yes.
What else? So we generally classify with Kupuswamy classification. That should
Yes,
be
sir,
uniform,
modified.
because when we are going to appear for exam, it should be universal, because the examiner can be from any part of this country. So based by the Kupuswamy. Secondly, you have taken abdominal girth and symphysis height in twins. What is the significance of gravidogram in twin pregnancy?
So generally, the symphysis fundal height and abdominal circumference is more as compared with singleton pregnancy. It generally doesn't correlate with the period of gestation, sir.
Yeah, naturally that is true. So gravidogram does not work like singleton pregnancy.
Yes.
So our aim of taking all these measurements are to see whether the patient is going to develop IUGR or something else. So the gravidogram does not work here in twin pregnancy. It is not necessary to take those abdominal girth height, symphysis fundal height for sake purpose. So it is not required. Now coming to this diagnosis, you have not written here which type of preterm labor she is in. You have written only DCDA twins.
Okay. Yes. Yes.
Because you are saying she is in preterm labor.
Yes, sir.
But by definition of preterm labor, she does not fall in preterm labor. So what is the definition of preterm labor?
Sir, the intensity and the frequency of pain, it should accelerate with time along with the dilatation of and shortening of the cervix.
Yeah. So here os is close uneffaced.
Yes,
Cervix is 2.5 centimeters.
Can be a false preterm.
Yeah. So you can call it as a threatened preterm labor.
Yes, sir.
So how will you manage this case now?
Sir, since first of all, we would like to start monitoring the patient by doing a non-stress test. We would like to do a NST of the patient. The fetal heart sound should be heard. Then since the mean gestational age at which the patient has presented is 35 plus 3 weeks. So this is the mean gestational age at which the patient with twin pregnancy presents. So till the coverage of steroids, we would like to give her tocolysis, and after completion of the steroids, we will let her deliver. Sir. We would like to do a ultrasonography also, since the last USG done was 30 weeks at 30 weeks. So we would like to know the exact weight, the AFI of the patient and the cervical length also.
A role of steroid at 35 weeks, and that too in twin pregnancy. Because generally we say that in twin pregnancy, the 2 weeks are more than what we are seeing here.
1 week.
So
Yes,
it is already 37 weeks here. So what is the role of steroid at 35 weeks?
No, sir, we will let her deliver if she has complained with
role of magnesium sulfate.
Sir, magnesium sulfate is generally given when in neuroprotective dose when the delivery is expected in the next 6 or 7 days. But here already the period of gestation has crossed, so I guess there is no need of giving magnesium sulfate at this period of gestation.
Any harm of giving magnesium sulfate? Because it is preterm, no? Because steroids we are not giving because lung maturity has not role with steroid after 34 weeks. But now it is a question of magnesium sulfate.
Sir.
So there is a sufficient evidence. We must give magnesium sulfate in that too in twin when we are dealing such preterm patients.
Okay, sir.
It's very important. Then how will you manage further?
Sir, the firstly, the FHS monitoring should be done throughout after doing the USG and after giving magnesium sulfate. Then we will let her go in spontaneous labor, and then during the first, second, or third stage of labor, the management is done accordingly.
Yeah, but this patient may or may not go in labor.
Yes, sir.
Because what you are saying is these are os is close, aniphase, cervix is long.
Yes, sir.
So these may be false labor pains. Okay. So will you observe for few hours or not?
Yes, sir. Observation will be.
That observation will tell you whether this patient will go in labor or
land up into true labor pains. Or
yes,
yes.
yes.
Sir.
So if she does not land up in labor, then how will you manage?
Sir, since this is a case of dichorionic diamniotic twins and it is an uncomplicated case, so the we would like to extend the pregnancy till 38 weeks, 37 to 37 plus 6 weeks. So weekly USG will be advised to her and weekly follow-up will be advised to her, sir.
Because her ultrasound is done at 28 weeks, then she has not had a single ultrasound.
Yes, sir.
So it's
yes, sir.
very
After
important.
doing the ultrasound. Yes,
yeah,
sir.
we have to see all these things. Then other investigation you want to assess because she is a primary rhabda, she is a twins, her hemoglobin
yes,
level.
the general investigation that should be done, that is the hemogram should be done, sir, because in twin pregnancy, generally anemia is seen. Then she must be counseled regarding.
If her hemoglobin is 8 gram, how will you manage further? This twin pregnancy, hemoglobin is 8 gram.
Sir, since she's at term gestation, we would like to go for blood transfusion, sir, because parenteral iron therapy wouldn't be much beneficial for her, because anytime she can land up into.
How many weeks are in your hand when she's not in labor?
Sir, 2 weeks, sir, 2 to 3 weeks max.
And what is the role of blood transfusion at 8 gram hemoglobin? Because blood transfusion has got specific role now. You cannot just say because it is near term and it is 9 gram, I will give blood transfusion. Or patient is in labor, it is 9.5, I will give blood transfusion. So blood transfusion has to be done only when hemoglobin is 7 or less than that.
7 or less than 7. Yes, sir.
For that you should not give blood transfusion. Okay. Then now this patient goes in labor. What will you do?
Sir, during the first stage of labor, continuous fetal monitoring should be done. Then oral hydration should be.
How you will do fetal monitoring? It is a cardiotopographic monitoring or auscultation?
Sir, CTG monitoring can be done, sir, because of.
It can be done. One. What is ideal thing? What is recommendation?
CTG monitoring, sir, because
monitoring now.
CTG monitoring, sir, because of the over distension and because of polyhydramnios, sometimes auscultation can mislead. That's why CTG is preferred, sir.
Okay, in difficult situation, you will do CTG monitoring.
Yes.
Next.
Then she should be encouraged for oral hydration. Then oral hydration, then continuous fetal monitoring. The 2 18 gauge boards should be applied for on both the hands.
What should we apply?
Sir, intracat, sir, both 18 gauge wide bore intracat should be applied. And
Blood will you take for cross matching or not?
yes, sir. For all the blood crossing, blood grouping and cross matching should be prepared beforehand. But because anytime she can land up into PPH, so the blood can be issued on an urgent basis.
Then
will
you ask her to restrict to the bed, or you can allow her movement, ambulation in the labor ward?
No, sir. We will ask her to ambulate if it is if the patient is still in first stage of labor.
So she can be ambulated. Okay, then what you expect her progress of labor? If she is in labor now, how you expect her partograph will be? Is it like a singleton pregnancy or it will be different? Progress of labor will be same like a singleton pregnancy. Same or different? You can tell that only.
Sir, same at the rate of 1.2 centimeters per hour.
Yeah, it depends on what type of presentation it is.
Okay, sir.
So now the next question comes: what are the indication of cesarean section in your patient with twins? Because she is a primary gravida.
Yes, sir.
And she is twins. So what are the indications of cesarean section for twin per se?
Sir, indication for elective cesarean sections is if the first twin is non-vertex, if the twin is monochorionic monoamniotic, if there is conjoint twins extending up to third trimester, then if she is a case of placenta previa, or
that is obstetric indication is different, but twin per se, these are the three indications.
Yes, sir.
Okay. And now, what is the management in second stage in twin pregnancy?
Sir, in second stage of labor, as soon as the first baby delivers, the immediate cord clamping should be done. Then
immediate cord clamping. Why?
Sir, because if there is a blood loss through the cord, it can lead to hypotension or acute TTS syndrome in the second baby. Sudden hypotension.
Are you sure? Because now a lot of things have been taught about delayed cord clamping. Even people are practicing for preterm labor and even in twins.
No, sir. Delayed cord clamping, but the
so what is how much delay?
60 seconds, sir. 45 to 60 seconds.
No, it is too early. Minimum 1 to 3 minutes.
1 to 3 minutes. Okay. Yes, sir.
Okay, so that you will do. Then next.
Then the active management of third stage of labor should be abandoned at this time. Then after delivering of the first and applying the clamp, delivery of the first baby, and after cord clamping, then by per abdomen examination, we will see the lie presentation of the second baby. Then if the baby, we will see for if the baby, second baby is longitudinal lie or transverse lie. If the baby has a longitudinal lie, then we will do a PV examination. Then ARM should be done. If the baby is cephalic or
will you wait for the uterine contraction whether they are adequate or they are reduced? Because generally the uterine inertia is seen after first delivery. So will you do directly ARM, or you will wait and you will observe first the intensity of uterine contraction?
Yes, sir, we will definitely observe if she is having adequate contractions or not. In case she is not having adequate contraction, augmentation of labor can be done.
How
then,
it is done?
Yes, sir.
How augmentation of labor is done in this patient?
Sir, generally in sir, first of all, the artificial rupture of membrane is done, and since she is a primary gravida, then oxytocin, low dose oxytocin can be started.
How much?
Sir, 2 to 2.5 units in Sir, in 500 ml of RL.
Why you are starting with 2.5 units? How much is one ampule contains?
2 ml and 2 ml, that is equivalent to 1 unit, sir.
How many units in one ampule? It is 5 units.
5 units. Yes,
so low dose, if you want to give, you can give it with 5 units also.
Okay.
So unnecessarily 2.5 unit and 2.5 units will be wasted. So 5 units also you can give low dose. But as such, I don't think that it is low dose or high dose when you are giving it 2.5 or 5 units. So you can always monitor. So you will start oxytocin. And how many drops you will start initially?
Sir, 8 drops per minute.
Okay. And then you will titrate. Okay. How much time you will wait for second delivery to occur?
Sir, generally the time spent between the delivery of the 2 babies should not be more than 30 minutes.
At the end of 30 minutes, if everything is okay, head is on perineum, contractions are adequate, FHS is good, maternal condition is stable, what you will do?
Sir, we will let the baby deliver if everything is good, and if the baby has cephalic presentation, and if the second baby has breech presentation, then breech extraction can be done. Then coming on to the second possibility, if the second baby is transverse, we can perform a ECV. Then it depends whether the ECV is successful or not. If the ECV is successful,
ECV is done before membranes are ruptured or after membranes are ruptured?
so generally before the membranes are ruptured. Then after we will see whether the ECV is successful or not successful. If it is successful, then we will progress as earlier. And if the ECV is not successful, then we will rupture the membrane. We will look. We will do an internal podalic version, but that should be done under anesthesia, sir. Then
for internal podalic version of undelivered second twin, is it not important to see the viability of fetus and weight of the fetus, or you can proceed for all?
Yes, the weight of the fetus is mandatory. If the second baby has higher weight than the first baby delivered, there can be problem delivering the second baby. So the weight also matters before the delivery.
Generally, for undelivered second twin, if it is IUD, if it MSB, it should be tried. Otherwise, if adequately large baby is there, IPU is sometimes dangerous.
Yes, sir.
Okay, then both the babies are delivered. Then what you will do?
Sir, then the active management of third stage of during the delivery of the second baby, 3 clamps should be applied, so as it is easier to differentiate that which one is first baby's cord and second baby's cord. Then active management of third stage of labor should be started by giving 10 units of pitocin, active uterine massage, and control cord traction.
Placenta.
Yes, sir. We will definitely examine the placenta to do the definitive diagnosis of the chorionicity by looking at the membranes, the lobes of the placenta, and the orientation orientation or origin of the cords.
In active management of third stage of labor in twins, will you do only that, or you would like to give some additional oxytocin in cases of twins?
Sir,
or you wait some bleeding to occur and then you will?
Yes, sir. Additional oxytocin of 20 units can also be started on IV drip, sir.
Yeah.
And along with continuous uterine massage, sir.
Yes. And then you will see placenta, and you will see amnion and chorion, and you will confirm your zygosity again.
Yes.
Okay. And if this patient bleeds profusely, how will you proceed?
Sir, even after giving pitocin, if the uterine contraction, if the uterus is not still contracted or retracted, we would like to proceed with the carbitocin. And since the patient, if the
how
patient
it is given carbitocin?
Would like to, yes, sir.
How it is given carbitocin?
Sir, carbitocin, it is given intramuscularly, sir, or 250 micrograms IM, sir.
How much?
250 micrograms.
Carbitocin, you are saying carbitocin or prostadine? Carbitocin is not 250 microgram. Prostadine is 250 microgram. PGF2 alpha is 250 microgram.
Sorry, sir.
Carbitocin, how much is the dose? Have you used carbetocin?
Sir, we generally use carboprostin or.
You use it, na? Carbetocin or prostadine? What?
The carboprostin is generally preferred.
So have you used carbetocin at any time? Not use, I think. Okay, so this is a newer drug you can use in patients who are developing PBH.
Yes.
So if such twins they come like this and they deliver animateful, it is well and good. So you have answered so far very good questions, intrapartum question. Now we can turn your question to the twins per se. So if my colleagues are there, if they want to ask question, they can ask.
So actually we are running short of time. So can we have a concluding statement from you?
Yeah. So overall, she has presented very nicely. There was a clarity of subject to her, and many questions she answered without any hesitation. There are few questions which generally happens for any PG student. They get blocked, so it is not an issue, and she will definitely perform well in her examination. So all the best.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you for your precious time. Thank you, Nikita ma'am. And thank you, Mane ma'am. Now we'll have a skill station videos.
Mane ma'am, would you like to summarize some expert points?
Mane ma'am, are we audible?
Okay, I guess ma'am would have, we are already running late. Nikita ma'am, would you like to add some comments? No ma'am, you are not audible. I think so you need to unmute yourself. Sanjita, please unmute Nikita ma'am.
Okay. The take-home messages for the multiple pregnancy cases, as the multiple pregnancy is carries the pregnancy-related complication, more risk of pregnancy-related complication as compared to the singleton pregnancy. Early diagnosis of multiple pregnancy is very important. And for the outcome, first is the chorionicity that is more important than the zygosity. First trimester ultrasound between the 11 to 14 weeks should tell about the gestational age, chorionicity. Then third is orientation and the aneuploidy screening of the patient. Monochorionic pregnancy, that this part has been left actually for the discussion part. Monochorionic pregnancy is at higher risk as compared to the dichorionic pregnancy. To monitoring of such pregnancy should be more frequent as compared to the dichorionic pregnancy. And it is said that it start from the after 11 to 14 weeks, we should start from the 16 to 24 weeks time is very important to diagnose the transfusion related complication in the monochorionic pregnancy every 2 weekly. Afterwards also, all throughout the pregnancy, we have to continue the ultrasonographic monitoring by every 2 weeks. And as far as and the dichorionic pregnancy, for the growth of the multiple pregnancy, every 4 weekly we have to do the ultrasonography. As far as mode of delivery is concerned, it depends on the what is the presentation of the first baby, then what is the chorionicity, and what is the fetal well-being of the baby, and then that's it. And one thing also left, that is what the role of multifetal reduction, in the multiple pregnancy. The previously we have to do only in the babies who are congenitally malformed or the genetically defected, but nowadays to increase the survival of the other babies, it is indicated. But it is a very very sensitive issue. Counseling plays a very important role here. The best time to do the multifetal reduction is, again, it's a
10 to 14 weeks time. There are some reasons to do that time also. At that time, we have ruled out all the aneuploidies, all the spontaneous abortion has been taken place already, and the devascularized tissue that produce after giving the after doing the reduction is very small. So that is also, and there are so many things we left that the management of the pregnancy with the single fetal device, role of management of pregnancy with the TTS and TAPS. Thank you so much.
Thank you, Nikita. That were really valuable points. I guess the PGs will definitely get help from them. Now we'll share some skill station videos. They are really very beautifully made. They have put a lot of efforts. Okay. आवाज share sound share.
Hello everyone. This is a video demonstration of PPH drill. This video is meant for sisters, doctors and paramedical staff working in labor room because they deal with obstetric emergencies. The specific learning objectives of this video are: at the end of this video, viewers or students should be able to manage a case of PPH as a part of emergency response team. At the end of video, the viewers should be able to enumerate the contents of PPH tray. They should understand the importance of facility preparedness for managing medical emergencies. They should be able to apply NASG, that is non-pneumatic anti-shock garment, to patients suffering from PPH or shock. An emergency response team consists of at least 5 members. But even less members are there, then the case should be managed effectively as a team. The team consists of a team leader, supplier, assistant, an observer, and a counselor. I, Dr. Prajakta Zunevar, am going to play the role of team leader. My job is to allot specific works to specific team members and keep follow-up of the works, whether they are done or not. I have to ensure whether the works are done correctly or not and guide the team members accordingly.
I am Dr. Apurva Patni and I am playing the role of assistant. My job is to perform all the tasks allotted to me by the team lead.
I am Dr. Ashwini and I am playing the role of a supplier to supply all the well-labeled drugs, instruments and essentials to the assistant and help the assistant.
I am Dr. Vishal and I play the role of the counselor. My job is to communicate with the relatives and counsel them regarding the condition of the patient and the line of management of the patient.
I am Dr. Sheila Jain and I am playing the role of an observer. The job of the observer is to note down all the events that are occurring. So it will be the events, the vitals of the patient and any medication that is being given according to the time. As you all know, documentation is a very important part.
Aditya is on morning rounds and she is examining a patient who has delivered about 2 hours back.
कशी आहे बेटा? काय नाव आहे तुझं?
माझं नाव प्रिया.
कसं वाटतंय प्रिया?
मला बरं नाही वाटत आहे आणि खाली ओढवलं पण वाटत आहे.
ठीक आहे, घाबरू नको. मी चेक करते, तुझा पॅड बघते एक वेळा. पाय जवळ घे बेटा. दोन्ही पाय. प्रिया, तुला थोडं ब्लिडिंग जास्त आहे बेटा. हा, पण घाबरू नको. मी तुला औषधं देते, त्याने बरं वाटेल. And emergency response team activate. Dr. Apurva, she is Priya, delivered 2 hours ago. She is having PPH. Please take her vitals. I will continue the uterine massage. Apply oxygen mask.
Ma'am, her pulse is 126 beats per minute and blood pressure is 90 by 60 mm.
Okay, Apurva. Secure 2 IV lines with 18 gauge cannula. Dr. Ashwini, please help her. Take blood samples for blood grouping and cross matching. Also take extra samples for other investigations.
2 IV lines have been secured. Samples have been taken for blood grouping and cross matching. Extra samples have been taken for other investigations.
Now Apurva, start IV fluids. $18 gauge cannula. Dr. Ashwini, please help her. Take blood samples for blood grouping and cross matching. Also take extra samples for other investigations.
2 IV lines have been secured. Samples have been taken for blood grouping and cross matching. Extra samples have been taken for other investigations.
Now Apurva, start IV fluids from both sides. Apurva, add injection pitocin 20 units in 500 ml NS drip. Dr. Ashwini, please label the drip.
Injection pitocin added 20 units in IV drip. The drip has been labeled.
Apurva, give injection tranexamic acid 1 gram IV stat.
Injection tranexamic acid 1 gram IV stat given.
Dr. Vishal, please inform OT sisters, blood bank officers and anesthetist. Also do counseling of the relatives.
Yes, ma'am.
Dr. Ashwini, please give me tablet misoprostol 1000 microgram. Priya, खालून औषध टाकते हा.
Normal pulse is 130 beats per minute and blood pressure is 90 by 60 mm of Hg.
Okay, Apurva. Tablet misoprostol 1000 microgram inserted per rectally.
I have informed OT, anesthetist and blood bank officer. I have also counseled the relatives of the patient.
Okay, Dr. Vishal. But patient is still bleeding. I think I should explore her. Cervical exploration should be done. Ashwini, give me tray for cervical exploration. There are no vaginal lacerations, no cervical tear and no RPOCs. Give me Foley's catheter for catheterization. Foley's catheter inserted. But she is still bleeding. Apurva, please take her vitals again.
Normal pulse is 128 beats per minute and blood pressure is 90 by 60 mm of Hg.
You start aortic compression, Apurva. I think we should do uterine balloon tamponade. Sister, please bring the tray. Uterine balloon inserted. But she is still bleeding. I think we need to shift her to OT. Priya, घाबरू नको बेटा. OT shift करो. Ashwini, please bring NASG. Dr. Vishal, help Dr. Ashwini. इकडे हो बेटा प्रिया थोडी. बस. Now we have applied the NASG, that is non-pneumatic anti-shock garment, and shifting the patient to OT for further management of PPH.
So in this drill, we have seen how the team works in coordination to manage a case of PPH. Let's see whether everything went well or not. Dr. Prajakta was acting as a team leader and she has properly designated the task to all coordination, and whatever task was being done, they were speaking out aloud. This is known as closed loop communication. This is very important because whatever task is done, whatever medication has been given is known to everyone so that there is no repetition and there is no mistake. We have seen that in between the patient was also reassured and advised not to panic. The counselor has talked to the patient's relatives and kept them updated about the patient's condition and what is being done for him. The OT sister was informed, the blood bank officer was informed about the anticipated need for blood or blood products, and even the anesthetists were informed because we have to anticipate that she might need some intervention in OT. We have also seen that continuous all throughout, one person was constantly taking down the notes and recording the events. Documentation is a very important part. Facility preparedness to manage an emergency like PPH is evident by the ready preparedness of all the team members who arrived immediately and prompt supply of all the requirements like the medication, the equipments, the NASD, balloon tamponade, etc. Thank you.
We'll have our next skill station video on stepwise devascularization.
So, we should be very well aware and trained. Postpartum hemorrhage is every obstetrician's nightmare. Incidence varies from 2 to 4% after vaginal deliveries and 6% after cesarean deliveries. So, we should be very well aware and trained to perform the life-saving procedures. After medical line of management and failure of compression sutures, we move ahead with stepwise devascularization of uterus. Uterine artery provides 90% of the blood flow to the uterus. Ligation of bilateral uterine arteries has a success rate of 80%. If it fails, we move ahead with bilateral ovarian artery ligation. So, uterus is elevated upwards and slightly away from the targeted uterine artery. Identify the uterine artery by visualization and palpation. Now, we'll pass number 1 observable suture through the myometrium 2 cm medial to and below the uterine vessels. Now we can see our needle has come out on the posterior aspect. We'll change the direction of the needle. And the suture is brought anteriorly through an avascular space in the broad ligament. Suture is tied securely. The procedure is to be repeated on both the sides. We should always look for bleeding or any hematoma formation on the posterior aspect of uterus. Now, we'll see the descending branch of uterine artery. Here, with the help of visualization, we are ligating the descending cervical branch of uterine artery. This procedure is repeated on the another side as well. If this doesn't suffice, we move ahead with ovarian artery ligation. Here, now we catch hold of the uterovarian plexus. We pass an absorbable suture below the plexus from an avascular area, and now we are on the posterior aspect. We change the needle and tape, pass it through the ovarian ligament and mesosalpinx, and tie the ligature securely. Repeat the procedure on another side as well. Again, not to forget to watch for any bleeding or hematoma at the site. If both bilateral uterine and ovarian artery ligation fails, we go ahead with internal iliac artery ligation. Internal iliac artery on either side arises at the level of lumbosacral intervertebral disc and in front of sacroiliac joints. It courses inferomedially over the pelvic brim and runs down to the pelvic cavity. At the upper margin of greater sciatic foramen, 3.5 to 5 cm from its origin, it divides into anterior and posterior division. The anterior branch supplies most of the pelvic viscera. There are two ways to approach the internal iliac artery. One is lateral to the sacral promontory and another is by opening the peritoneum over the external iliac artery from round ligament to infundibulopelvic ligament. This is the approach which will be shown in the coming video. When both the internal iliac arteries are ligated, the pulse pressure distal to the point of ligation decreases by 85%. This causes change in the pressure and it will promote clot formation at the site of bleeding. Effectivity of internal iliac artery ligation varies from 40 to 93%. As collateral formation takes place, patients do not face problem of infertility in further period. So let's have a look at the internal iliac artery ligation video. So we are holding the round ligament. We have identified the infundibulopelvic ligament. In between these two, we'll catch hold the peritoneum and open it. Now we'll dissect the space. We'll identify internal iliac artery at its origin from common iliac artery at the medial margin of psoas muscle. See, we can see the external iliac artery, internal iliac artery, and the ureters. This is ureter in the medial flap. This is external iliac vessel till the common iliac, and this is the internal iliac artery. Now, we'll dissect the vessels along their way. This is to prevent injury. Our first ligature will be tied 2 to 5 cm distal to the origin of internal iliac artery. We are passing the mixture from lateral to medial direction to avoid injury to external iliac vein. Second suture will be passed 0.5 centimeter distal to the first suture. It will prevent recanalization. We should always check for the peripheral pulses when we tie the internal iliac artery. Thank you.
On behalf of NOGS and Department of Obs-Gynae, we thank you. We thank the judges, Dr. Aparna Vane ma'am, Dr. Jitendra Deshmukh sir, Dr. Anjali madam, Dr. Anisha Gala ma'am, Dr. Reena Vani ma'am, Dr. Dipti Srivastava ma'am, Dr. Kanchan ma'am, Dr. Seema ma'am, Dr. Bangal sir, Dr. Rujuta Fuke ma'am, Dr. Monica ma'am, Dr. Shailesh sir, Dr. Sandhya Pajay ma'am, Dr. Madhuri Patil ma'am, Dr. Kadapa sir, Dr. Nikita Vijay ma'am. We also thanks all the participants for actively participating. We thanks the audience. We thanks the Yash and the audiovisual team for their technical support. Here we do not end it. This was the first day of our case discussion. Tomorrow again, we'll meet you sharp at 12. Thank you all.